Morning, everyone, and welcome to the Paramedic Program Research Day at Fanshawe College 2022. We're delighted to welcome you here. I can see people signing in on YouTube at the moment. We have our student presenters here backstage in the Zoom meeting, and we have our first invited speaker as well. So thanks for taking the time to come here and share in this research with us. The students have been working on these projects since April, well, probably January really of last year, and came to a proposal level in April of last year, and then went through ethics applications and have been collecting data and analyzing it and putting it together for probably the past year or so. So it's a significant commitment by a bunch of students who also have the rest of the paramedic program to contend with as they're going through this. And we've discussed this before at previous events and in a couple of publications, that really this student-led research and this piece that of students contributing, ideas into the literature is really important. And so whether these get seen through to publications or not, the fact that we have paramedics going into the workforce now who have questions that they want answered and who have the skills to be able to start doing that, I think is a good thing for the profession. So the way today will work, we have an agenda that is available on the Eventbrite page, and you can access that there, and I'll quickly go through it. We're just doing our introductory pieces here, and that'll take the next few minutes. We'll move into our opening keynote from Rory Marshall then, and then we move into some of the student presentations. We have a short break then at 10:40, back into student presentations again, followed by another short break, back into the final student presentations, and then we have a closing keynote speaker, Jennifer Bolster, who's also from BCHS. And then I'll give a couple of minutes and maybe Jennifer just closing remarks and thank yous and things like that. So anyone who has registered for this event on Eventbrite, your name is recorded, and we will provide those names to London Health Sciences Centre and Hamilton Health Sciences for CME credits. So we have your details that you gave on sign up, so we'll take care of sending those names to the base hospitals. Anyone who's outside of those base hospital system, or who's in a different country, if you need something around, that you registered for this event, in a few weeks' time, 2 to 3 weeks' time, everybody will receive an invite to a survey that will ask you about the day and the topics that were presented. At the end of that survey, after you complete it and submit it, there is a CME certificate that you'll be able to download and fill in with your details. And so that, combined with the registration details that we can provide, should be enough for any regulatory body or any organization that's looking for your CME credits for recording purposes. If that's not enough, feel free to reach out to me by email. It would have been in your registration email, and I will be able to look at, providing a different way for you to prove your attendance and your registration at this event. So just before we get started, a few acknowledgements for the ongoing support, the Centre for Research and Innovation and the Ethics Board at Fanshawe as well, who have approved all of these studies that you're going to hear from the student groups. The Fanshawe School of Public Safety and Jennifer Doyle, who's here in backstage as well, for their ongoing commitment to research in this paramedic program. It's a relatively rare thing across Canada to have primary care paramedic students not only learning about research, but doing research as well. And we have had success over the years in putting some of these projects into the literature and presenting them at conferences, both at home and abroad. And so I think that commitment from the program and from the school is really important to signal, how important research is to the profession going forward. So I personally want to acknowledge the commitment from all of those people, and without that support really and that commitment, this wouldn't be able to happen. To the base hospitals, to SWARB and CPER, and we mainly focus on those because that's where a lot of our graduates attend, is services that are covered by those two base hospitals, who have been very generous over the years in awarding CME credits to this event, and making it something that they encourage paramedics to come to this and learn about what the students are working on and get an idea of maybe future directions where things are going. So that acknowledgement is also an important one. And then finally, the McNally Project for Paramedicine Research. I do have a conflict in that I am co-chair of the McNally Project. The McNally Project, if you're not aware of it, is a grassroots initiative of paramedic researchers from across Canada. Started with 5 or 6 individuals in 2015, and we're currently sitting at 96 individuals across Canada. Everyone from paramedic students who are interested in research to paramedics who hold academic positions and have PhDs, and everyone in between. And so if you are interested in research as a paramedic who's on the road, or as someone who's maybe starting a graduate degree or something like that, please reach out to the McNally Project, and we'll welcome you with open arms. It's a community for paramedics who are interested in research and who want to know more about it. And they have also supported the event today. The 2 guest speakers are members of the McNally Project, and we are using the McNally Project's Zoom account as well for this live stream to YouTube. So with that, and a bit shorter than I had expected it to be, I will ask Jennifer, do you have anything that you want to add before we get started?
Alan, just to continue on with the thank yous, a big thank you to yourself for the support that you've offered the students over the last 2 years and the guidance that you provided them to be able to even develop these projects right from the grassroots. So a big thank you, and thank you to everyone who's watching and joining us today. I'm really excited for the next few hours.
Thanks, Jennifer. Okay, so with that, I will end my share here and I'll hand over to Rory. And Rory is a primary care paramedic with British Columbia Emergency Health Services and a PhD student at UBC. And he is looking at pre-hospital management of intimate partner violence. And I'll leave him add any extra introductions he wants, but really excited to have Rory speak here. I think the topic he's looking at is extremely important and has been recognized elsewhere in paramedicine in different countries. And it's good to see that somebody here in Canada is looking at this and realizes, the value that it can add. So over to you, Rory.
Excellent. Thanks so much for the introduction. We'll just get everything set up here. All right. Let me know if there's any problems with hearing anything. Just before we get started, I want to say a big thank you to Dr. Alan Batt and the whole Fanshawe College for inviting me today. It's great to be part of such an awesome event centered around paramedic-led research. So thrilled to be a part of it, and thank you very much for having me. So if we do work in the field of paramedicine long enough, undoubtedly someone will ask you, what's the worst thing you've ever seen? And it's kind of an odd question because they normally ask it at a cocktail party or when you're out for coffee. And I think a lot of the time they're expecting a heroic story like you might see on Chicago Fire, where there's this crazy rescue and blah, blah, and it was really dangerous, but then in the end, it all worked out. And what they don't see is that those calls that are kind of these really difficult calls that are the worst thing we've ever seen are traumatic and dangerous and bad. Because when it's bad, it's really bad, and bringing up those memories is not always great. But if we think about our training as paramedics, we're trained to deal with those bad things. It's like cardiac arrests, the bread and butter of paramedicine. Traumas, bread and butter of paramedicine. Respiratory emergencies, bread and butter of paramedicine. But if we shift gears a little bit, how often do we go to high acuity calls? Well, 40% roughly of ambulance calls are dispatched as medium or high acuity. So that's a code 3 lights and sirens response. But a little under 1% are deemed high acuity by paramedics. Less than 1%. So no, you're not dying. Most of our patients aren't imminently dying. However, there's a bit of a change in paramedicine, and we're seeing it more and more as the roles expand now. And not dying doesn't equal does not need help. So just because someone's having a health emergency that isn't going to immediately kill them doesn't mean we shouldn't be doing our absolute best to support them through their health issue. Q, intimate partner violence, formerly termed domestic violence. This is just a kind of a catch-all for any emotional, physical, psychological or sexual violence from an intimate partner or a former intimate partner. Now, unfortunately, this is a very prevalent and long-standing problem in society and in healthcare, and we're not very good in general at managing this. Now, for a little more background on intimate partner violence, 1 in 3 women globally will experience intimate partner violence in their lifetime. And I'll say women because it is predominantly male violence against women. There are other populations that can go the other way, but that's the dominant population that we see this terrible problem in. And so 1 in 3 women have a lifetime experience with intimate partner violence. And in Canada, we actually see more intimate partner violence reported than the global average. Now, some additional piece to this, in intimate partner violence and physical intimate partner violence, we're seeing this new link emerging between brain injuries and intimate partner violence. And shockingly, as many as 92% of women that experience intimate partner violence also suffer a brain injury. And this can be a major problem when it's missed in those kind of minimal concussive, subconcussive events, because now when you've got women who are maybe have sought refuge at a women's shelter, and in 30 days they've got to do XYZ, get housing lined up, employment, deal with the psychological trauma, the physical trauma, all those things. But now they're doing that with a brain injury. And so it's just another piece of the puzzle. So for further context on in Canada, intimate partner violence, for every 1 NHL player every year that gets a concussion, there's over 5,500 women. Just think about that for a second. 5,500 women for every 1 NHL player that gets a concussion. Crazy numbers and a huge problem. And unfortunately, there's not a lot being done on the greater scale. So to give you some real numbers, I live in Kelowna. There were about 1,000 calls that the RCMP responded to for assaults last year of any kind. That's from your bar fights to intimate partner violence and everything in between. Of those 1,000 calls, 482 were intimate partner violence identified. So for you math buzzes, that's about 48%. That's shocking. About half of assaults that are attended by police are for intimate partner violence in Kelowna. And if you think about all these numbers and these statistics that I'm throwing out, there's so much more likely in unreported incidences. When people are in situations where they can't call, it's not beneficial for their safety, as crazy as that sounds, to call and ask for help. There's lacks in resources. So there's a lot of incidences that don't go reported. So that number is likely even higher. There's also a lot of incidences where healthcare staff, whether it's paramedics or people at the hospital or first responders like the police, and intimate partner violence is not identified. And that's another thing that we need to improve on as well, or could improve on. There's also, those numbers don't account for calls that only paramedics go to, and so many more. I mean, paramedicine's a gray zone in a black and white world, so there's a lot of gray area there. So for intimate partner violence survivors accessing supports, there's some real barriers in the way of them getting the care they need. So many don't get the care they need. And a big piece here is the stigma around intimate partner violence. It's just got this whole set of thoughts behind it that make accessing care very challenging. And so then as a result, a lot of these women don't. There is the access itself. Maybe they're being controlled by their partner. They can't get the car. Maybe they've got the kids at home. They can't look at that. Maybe there's all these different problems. So Then there's other barriers to care. A lot of the risk factors that increase the likelihood of intimate partner violence are also risk factors increased with kind of falling through the cracks in the healthcare system. So can see how this is starting to snowball up and all compound together. So there are supports. Women's shelters do a phenomenal job. They're working on a huge problem with a lot of the time very little funding and just some really great people. There are some specific clinics in British Columbia here. We have the Embrace Clinic, which is specifically for survivors of intimate partner violence and sexual violence. And there are resources. There's probably not enough, but that's another story. But the biggest way that survivors of intimate partner violence enter into the healthcare system is through the emergency department. Like a lot of people, we don't have access to general practitioners. There's a shortage in your area. They're not around. Where do they all end up? The emerge. So that's no different here. So in the pre-hospital setting for managing intimate partner violence, there's a thing we're really good at, which is acute injuries. So if someone's unconscious and they're barely breathing after an assault, and remember, we can handle the physiological aspects of that. Now, this doesn't happen all the time, but anytime we identify intimate partner violence, it should be documented. Continuing that, it should be handed over to the triage staff at the hospital, whoever you pass on your information to. That link's got to be there. But realistically, it's the acute injuries, it's documenting it, it's doing your handover and then going, oh, wow, well, we've got another call. And that's kind of the approach currently. So if we think about this in a different context, when Anderson Silva broke his leg, it was pretty obvious. So when someone made an emergency call after this, let's say, it's obvious. They saw an event, broke his leg, gets relayed to the dispatcher. They go, oh yeah, sounds like a broken leg. They send an ambulance. The ambulance goes, oh, we were told someone broke their leg. They get there, looks like they broke their leg. Okay, let's treat this. Let's get it packaged up. Let's go to the hospital. Get to the hospital. So now we've got, well, the caller said this. We saw this. This is what we did. We think it's a broken leg. They tell that, and that's a good step to get good care at the hospital. So then that all goes through, like, it's very obvious. The problem the entire time is very obvious. The care is very obvious. The recovery care, whether it's the physio or whatnot, this is all very clear. And then it gets the patient back to patient normal. So how they were for what they like to do. Now, the problem here with, let's call this lady Sue. The problem with Sue, when she's sitting in the emergency room, doesn't want to talk to anyone, is it's not obvious. So let's say if something happened at home for Sue, now there's a barrier there in that if she's just been assaulted by her partner, she's not going to be able to call, potentially, if she would like to call for help. Maybe he's taking her phone. Maybe he's physically stopping her from calling. Maybe she's embarrassed about calling. Maybe if she does call, she'll say it's for something else, because there's all this just challenge around that. So now the dispatch response and the 911 call are kind of broken up. So when we get there and the partner's still there, we're trying to figure out what's going on. Maybe Sue's not being very forthcoming. We haven't built a good relationship with her. And there's a barrier there. So now, let's say there's no acute injuries here. And we take Sue to the hospital. Yeah, we don't really know what's going on. She's acting kind of weird. So it seems like they've been drinking maybe, or I don't know, like, I don't know, that neighborhood's not very good. Something's always going on. So now maybe it's biasing the hospital care they get. Well, if there's no injuries and we gave a crappy handoff report, are they going to get to a point where there's good recovery care? Probably not. So is that patient going to return to patient normal? And let's say if it's this first time this has happened, and they're living an abuse-free life prior to that, are they going to get back to that? Or is it going to happen again if they're not getting any support in this situation? That's the problem here, is because Anderson Silva can go back to fighting in the MMA again. But unfortunately for Sue, she might have to go back to fighting at home. And then she might end up in the emerge again, or worse. And that's the problem. So I get this question all the time, speaking with colleagues about intimate partner violence and pre-hospital care. It's like, what can we really do as paramedics? All we do is take them to the hospital. And that's just untrue. That's kind of an archaic way of thinking. If you're in the taxi driver mindset of you call, we haul in paramedicine, you're probably falling a little bit behind the times. Okay, the role of paramedics is expanding, our scope is expanding, and what we're doing as allied healthcare professionals goes beyond putting people on spine boards, throwing a collar, taping their head down, and going like we used to do every time for everybody a long time ago. All right, that's just not the future. The future of paramedicine is progressive. The future of pre-hospital care is progressive, and there's a lot of opportunities there. So we have a unique insight into people's lives. It's a real privilege to be invited into someone's home, and we get to do that every day. It's fantastic. And we get to look into their life that the rest of the healthcare system doesn't get. The nurses don't know what their house is like. The doctors don't know. The x-ray techs lab, nobody knows what that house is like, but we've been there. So that's a huge advantage in our assessment of how things are going. First, and then we've got a private ambulance compartment to speak with people in. Yes, there are rooms at the hospital, but especially now in the current setting of everything, they're not always private rooms. If there are rooms available, it's probably more likely a stretcher in the hallway. And are people going to be very forthcoming about very intimate personal issues when they're surrounded by other people? Probably not. I mean, do patients always tell us the truth anyway about silly things like if they're on heart medication? No. So if it's something even more personal than that, having a private space where we don't have 5 patients we're juggling, we have 1, and we're stuck in traffic, so we've got a little more time, we can have a space to facilitate those conversations. And we can also have rapport. This is a huge thing in the treatment of anybody, but building that rapport is a really good opportunity to set people up to get the best healthcare they need. And in intimate partner violence settings, that's huge. And we also set people up for how they're going to be treated in the emergency department. To a certain degree, what you say when you hand someone over will change how they are treated. So we have kind of the opportunity to do the best job we can for everybody all the time. And we can actually refer patients to resources without it having to go through a doctor. And we'll get into that a little bit more later, but there's a lot of opportunity here. This is just 5 points. But as much as there's opportunity, and you could put the same title on this slide, but there's a lot of gaps. So in paramedic education, there's not a lot involved with intimate partner violence, even less linking that to brain injury. So in the current National Occupational Competency Profile by the Paramedic Association of Canada, there's a point for child abuse, geriatric abuse, physical and mental impairment, people with those impairments abuse, but there's no mention of domestic violence, intimate partner violence, anything like that. So it's not even in our competency profile. We're kind of head in the sand here. So then those competencies track to our provincial education programs, and shockingly, they're missing there too. And then depending on your service, you might have an in-service course, but most of the time this is pretty lackluster from what I've seen in my dealings with other paramedics discussing this with them. So the education, which is a huge piece of this, is just absent. So then our knowledge and awareness as paramedics is absent or lacking, let's say. And then because our education is lacking, our knowledge and awareness is lacking, we don't have any guidelines. We don't know how to approach these situations, or if we do, it's from personal experience, not because we're being supported on this. And then because we've got no knowledge and awareness, no guidelines, we're not screening people for this. And this happens, and we're just missing it constantly. We don't know the common injuries that go with the subacute violence that are harder to tell. If someone's being strangled instead of punched, there may be no signs at all. And if you have been strangled, your risk of stroke goes through the roof. But you may never see anything externally. And if you haven't built a situation to get that kind of history, you would never know. So just thinking about these different things in situations where it's possible. So there's just a lack of the common injuries. Our documentation is also not set up well. I've combed through our PCR system, and there are 2 spots where domestic violence is mentioned, well, one indirectly and one legitimately, and it's in a mental status assessment, which is non-mandatory 15 fields away. And I'd never seen it before I went looking for it. So there's a lot of transitional errors because our documentation can lack there. And we have the option to refer patients, and that's something we'll get into in a minute here. So these are the research objectives. And because this project's very new, these are ongoingly being developed, but this is what we've come up with so far to better support and set up paramedics to manage intimate partner violence. So the first one is to develop and deploy good pre-hospital intimate partner violence education for paramedic students. The second is to do the same, but for paramedics. We've got to catch everybody up, not just the new students. Then we've got to develop pre-hospital specific intimate partner violence screening tools, and then brain injury screening tools. Because that link is so clear and so prevalent, we've got to do both. We've got to develop guidelines for managing those patients and integrate those tools into it. Then we've got to get the tools and the guidelines into our patient care reporting so we can follow this through and make good documentation, because as annoying as it is, documentation is crucial to our job. And our documentation, although I know a lot of people think the physicians never read it, the nurses never read it, the research on that shows they read it. So do a good job. And the final one is to integrate paramedic initiated referrals. And this is getting things started like a social work consult for your patient as a paramedic. We have the option to do this. So those are the research objectives. For the pre-hospital education, how we're going to get at this is survey paramedics and students on their current knowledge, awareness, and practices surrounding intimate partner violence. Then we're going to pick out the gaps from that and see what they think would be best and combine that with the knowledge in the field, deliver some pre-hospital education. And our focus with this is we want it to be interactive, we want it to involve critical thinking, and we want it to be real and practical. We want this to be education built by paramedics to better paramedic practice. And then do a post-learning assessment to see, have we actually achieved our goal? Has learning occurred? Now, on the brain injury and intimate partner violence screening side, there's a lot of brain injury tools, but there's none specifically for pre-hospital care. So we want to develop tools for screening for intimate partner violence and intimate partner violence related brain injury, kind of similar to you would have a fast van screening for stroke, where your fast is your initial, and then if they're fast positive, let's do the van. Now, we need these tools to be feasible, we need them to be beneficial, and we need them to be practical, which is always a challenge, but that's kind of big pieces of this. Now for guidelines, Simon Sawyer and the group there out of Monash in Australia have done some phenomenal work in pre-hospital intimate partner violence. And they've developed, as far as I can see, the only guideline for managing these patients. And we want to expand on that here in Canada in a new setting, adding those brain injury pieces. So We want to kind of follow their model and get better recognition, better responses from paramedics, screening for IPV more than we should, or not more than we should, more than we do, as much as we should. Screen for brain injury when possible, get really clear and easy documentation so that we don't have those translational errors from paramedics to healthcare staff at the hospital. So everybody is on the same boat. Be able to get those referrals, like we're talking about, initiated by paramedics. Yes, this would be good. This would be in the best interest of my patient. Let's get that going. So we want to develop a guideline, and we want it to be reasonable for paramedicine. Like, you can't do a 20-step system for something. It's got to be feasible, and that's why it's so important for paramedics to be doing this pre-hospital research and any pre-hospital research, because people that aren't paramedics may not have a very good understanding of what's reasonable within the context of paramedicine. And of course, we always want it to be evidence-based, which is, there's not a lot of evidence currently. We've got to keep building that base as well. And the part nobody really enjoys but is crucial is the reporting, getting an IPV screen into the assessment, getting a brain injury screen in, getting an impression code so we can at least, like, things like this that we're missing that are super easy fixes, and then start those referrals. So when we've got people in, social work consultations, patient safety alerts, if you believe they're imminently in danger, if they tell you they're imminently in danger, they very likely are. Ensure this information is being transferred. Like, we've got to keep that chain down to make it all work. And why do all this? Like, this is a huge undertaking. This is a big change to paramedic practice. And it's like, people ask, why do this? Why make that the thing? There's other things you need more. Well, yes and no. But paramedics can be an intimate partner violence resource in the same way that in a lot of situations, paramedics should kind of be experts on resuscitation. We can be the experts on intimate partner violence in this setting and be able to pick it up. So health practitioners that are more educated detect more intimate partner violence than uneducated practitioners in the same population. So it's not the amount of violence that's changing, it's how much we understand and realize and recognize it. And if paramedics can do that, we can be a lot more aware. And if we've been educated and we're aware and we're trained on how to deal with it, we can be huge advocates for our patients and get them the better care they need. Because currently there's those huge gaps. So if we remember this timeline, unfortunately, there's not a lot we can do about the 911 call. That's just the nature of the beast. But what we can do is take down the barrier to pre-hospital care and do a great job of recognizing and assessing and having your spidey senses up, all the things surrounding intimate partner violence. We can then relay that to the hospital and support these patients in getting the best hospital care they can, and that this process is tracked all the way through so that now they're getting the best recovery care and they can be supported and hopefully get back to a patient normal. So Sue can go from sitting on the bench in the emergency department in tears, not wanting to talk to anybody, back to where she wants to be in her life. So the major takeaways here: currently, paramedics are not well equipped to deal with intimate partner violence in Canada. We need pre-hospital specific education. We need pre-hospital specific tools. We need pre-hospital guidelines. And with all this, we can advocate for patients, link them to what they need, and become better practitioners in healthcare. Thank you so much. I appreciate the opportunity for being here, or for having me here today. And it's been a pleasure to be involved in this research day. So thank you.
Thanks, Rory. That was a great presentation. Thanks for sharing your work with us. I don't have any questions on YouTube right now. Is there any questions from anybody in the Zoom meeting for Rory? We have about 5 minutes that we can give to questions if you have them. So there is a question just popped up on YouTube. So any suggested opening questions to a patient that could open the conversation about possible intimate partner violence?
Yeah, I think obviously it's very situational and depends, but I know some of the training that's coming out on asking about suicide and suicidal ideation, not they're the same, but is just clear and direct. And I think if you can build that rapport and just ask clearly and directly, that's kind of our big piece. And it'll be something like, has this happened before? Like, or do you feel safe at home is a really good one. Is there anything that doesn't make you feel safe? And that feeling of safety, if they're willing to disclose that they're scared or feeling unsafe to you, that's a good step in that they'll be able to trust you and open up if they'll feel comfortable answering that question.
Great, thanks, Rory. And there's another question that's popped up here as well. So that question there was from Scott. Thanks for that, Scott. And Justin has asked, are there specific screening tools you would recommend? And I guess the one from Monash, would you recommend that for use in Canada, or do you think that there's some barriers to that?
I think the guideline out of Monash is a very good place to start at the moment. If you go to kind of that, there's a Fletcher paper in there that had the graph on it with, that must have been 10 different tools. And just having a read through, and you don't have to follow any specific tool, just kind of glean the parts that work for you, and until we've got a better pre-hospital specific option. But there's some really kind of quick 3-question ones that are a good tool, like the STAT is a really good one, as well as there's just one called the pre-hospital violence screen, or not the hospital violence screen, which is another good place to start. So that's what I'd recommend for now, and hopefully we can get a better one developed here in the next little while.
Updated answer pending. That's great. Thanks, Rory. And again, thanks for sharing your work with us. Lots of positive feedback coming in on it. And yeah, looking forward to seeing where your work goes from here.
Excellent. Thanks so much, Alan. And thank you everyone for having me today.
Thanks, Rory. Okay, so next up we have a student group presentation. So Jordan Dunn, Nicole Lynn, Melanie Fong, Julia Murray, and Kayla Benwell are going to present on their research around confidence levels during cardiac arrests. So over to you.
Hi, everyone. My name is Jordan, and our research topic is on how confidence levels potentially impact patient outcome when responding to out-of-hospital cardiac arrest calls. Throughout this presentation, you'll have the opportunity to meet Julia, Nicole, Melanie, and Kayla, and they'll provide some insight on our research findings. So first, we'll talk about the importance of our research, some background information on previous literature, how we conducted our research, and some of the limitations that we faced. And we'll also talk about the results of our study and some trends that were noted. And then we'll conclude with some possible implications of our research. So according to the Heart and Stroke Foundation, an average of 35,000 out-of-hospital cardiac arrests occur each year in Canada. This number is expected to rise because of the increasing lifestyle risk factors amongst the public. And research has shown that paramedics who have responded to at least 15 out-of-hospital cardiac arrest calls within the preceding 5 years were 21% more likely to achieve a ROSC. So we asked ourselves, what exactly does confidence have to do with these numbers? A paramedic who responds to their first VSA or may not have responded to a VSA just yet, or someone who, compared to someone who ran this call just a couple months ago, their confidence levels undoubtedly so wouldn't be as high. Although out-of-hospital cardiac arrests account for a very small number of emergency calls, paramedics should be prepared and confident in their abilities when dealing with such a high acuity call. Our research aimed to determine if there is a direct correlation between the frequency of cardiac arrest calls that a paramedic respond to and how this can increase confidence levels, therefore possibly improving patient outcome. Not only does the research attempt to identify a trend between patient outcome and confidence, but it also raises some awareness for paramedics who perform more frequent refreshers outside of training that services already offer. So to sum up all this information, numerous studies have identified a correlation between the frequency of cardiac arrest and patient outcome. However, will additional education close this gap? So up next, Julia will briefly explain some previous research related to this topic.
Hi there, my name is Julia, and I'm going to be going over and giving some background on our literature review. So while researching and exploring our topic, we found a few articles that helped develop our thesis and gave us a general direction for our research. So the first article we found was a study conducted in 2009 by Gold and Einsberg. So they were examining if there was a correlation between experienced paramedics and survival rates in out-of-hospital cardiac arrest. So the results from the study showed that paramedics with more experience during out-of-hospital cardiac arrest had a 2% increase in the likelihood of patient survival. So another study, which was conducted by Ways in 2017, found that paramedics who participated in less than 10 cases of out-of-hospital cardiac arrests had a 22.2% chance likelihood of obtaining a ROSC, so also known as a return of spontaneous circulation. So comparing to those who responded to more than 10 out-of-hospital cardiac arrests, had a 28.9% chance of obtaining a ROSC. So both the studies I just mentioned kind of indicate and support that paramedics with more experience and increased skill level perform better during out-of-hospital cardiac arrests. So both the studies got us to think and believe that having additional cardiac arrest training will increase a paramedic's confidence in managing a cardiac arrest and will hopefully lead to an increased number in patient outcomes. So up next, Melanie is going to be talking about the methodology of our research.
Hi, I'm Melanie, and I'll be discussing our methodology. We used a survey-based quantitative research design that targeted primary care, advanced care, and critical care paramedics in Canada. Our survey included 9 closed-ended questions with set answers to allow us to assign values to the responses, which we were then able to put our results into bar graphs and charts. Then there were no exclusion criteria of participants regarding demographics. Our questions entailed asking designations, so PCP, ACP, or CCP, years of field experience, frequency of running a cardiac arrest call, how often a ROSC is achieved, the paramedic's confidence levels in running a cardiac arrest according to the ALS, years of field experience to feel confident, and lastly, if they think a semi-annual or annual refresher on cardiac arrest procedures would be beneficial. With that being said, we were able to spot trends between experienced paramedics, confidence levels, and patient outcomes during an out-of-hospital cardiac arrest. The questionnaire was active for paramedics to complete during June 2021 to September 2021. A consent form was required to be filled out before the questionnaire link was accessible. Paramedics could be part-time or full-time and would be able to access the online survey through SurveyMonkey or a Facebook group called Ontario Paramedic Students, and through our Fanshawe paramedic professors to send to their colleagues. So limitations to the study include the geographical location, as only Canadian participants were involved in the research. Additionally, our sample size was relatively small, which can have a negative side effect to finding a statistically significant result. We were limited to only 40 participants due to the survey generator we used. Lastly, as first-year students, we were unaware that some services offer semi-annual training on running a cardiac arrest. Next, Nicole will be discussing about results and trends.
So I'm Nicole. I'm going to be discussing our research results. So our study collected responses from 40 paramedics that were working in Canada, all with different varying levels of education. So 28 responses were from PCPs, 11 were from ACPs, and we had 1 response from a CCP. Our paramedic participants all had varying levels of experience as well. as averaging hours worked per month. So 8 responses were from paramedics that had 0 to 2 years of experience, 14 responses with 3 to 4 years of experience, 4 responses with 5 to 7 years of experience, and 14 responses with over 10 years of experience. So although they all had different levels of experience, 65% of our participants all worked over 156 hours per month. So of the 40 participating paramedics in the survey, 3 responded with having 0 to 2 cardiac arrest calls annually, 13 responded with 3 to 6 calls annually, 8 responded with 7 to 10 calls annually, and 5 responded with 11 to 14, and 11 responded with over 15 cardiac arrest calls per year. Of the 40 working paramedics, only 1 said they get a return of spontaneous circulation, a ROSC, every time they conduct a cardiac arrest call. 3 participants reported getting a ROSC often, 14 participants sometimes get a ROSC, 18 participants only get a ROSC rarely, and 4 participants had never obtained a ROSC. So in our survey, we asked the participants 2 opinion-based questions. Firstly, about their confidence levels while running a cardiac arrest according to the ALS standards. And secondly, asking how many years of experience it took for paramedics to feel confident when treating a pre-hospital cardiac arrest. So 8 participants said they were neutral in their confidence. 16 said they were confident. 16 said they were very confident and when running a cardiac arrest according to ALS standards. So after we asked how long it took participants to feel that confidence, 19 said it took them 0 to 2 years for them to feel confident. 18 said it took 3 to 5 years to feel confident. Other responses, including 2 paramedics, said it took them 6 to 7 years to feel confident. And 1 person said it took them 10 plus years to feel confident when running an arrest. Finally, we asked them, would your confidence increase if you participated in semi-annual or annual out-of-hospital education? So 6 participants, so 15% said no, their confidence wouldn't increase with training. 40% responded yes, semi-annual training would improve their confidence. And 18 participants, so 45% said yes, education would improve their confidence. So some of the trends that became a little bit more obvious when we were analyzing our data, it's probably common knowledge or easy to consider that, yes, with experience and years of experience as well, there was an increased confidence. So the most confident medics were those that had run over 15 cardiac arrest calls in a year or had 10 plus years of experience. So next up is Kayla, and she'll be talking about the implications of our research.
Hi, I'm Kayla. I'll be talking about implications and applications of our research. So in conclusion, paramedics that responded to our survey suggested annual or semi-annual out-of-hospital cardiac arrest education would improve their confidence. This conclusion can be applied to provide out-of-hospital cardiac arrest to working paramedics. Accompanying the additional training, paramedic services can be more open-minded to the idea of continuing education and the need for additional refresher courses in cardiac arrest calls, as well as other high-stress calls. Our research asked only working paramedics about their confidence running a cardiac arrest call, but other first response agencies such as fire and police should also be included in the conversation. Pending the results of a multi-agency survey could mean providing additional training for firefighters and police officers along with paramedics. These agencies also work together during cardiac arrest calls, so having joint training may also be beneficial to confidence not only in paramedics, but also trust between the different agencies, that everyone participating knows how to properly perform each intervention and knowing which steps come next in the call. Also, paramedic confidence is key in any call, but especially during a cardiac arrest call when there are several life-saving interventions to be done in a short amount of time. Therefore, improving paramedic confidence during high-stress cardiac arrest calls means a reduction in steps being missed and hopefully lead to better patient outcomes, which is always a priority during any call. Lastly, the more times something gets done properly leads to that task becoming automatic and subconsciously done. Having this happen during a cardiac arrest call means that other aspects can be done consciously, leading to the call becoming more efficient. Additional training would lead to this efficiency during a cardiac arrest call. In closing, annual or semi-annual out-of-hospital cardiac arrest training should be provided to working paramedics and other first response agencies in order to increase confidence and reduce the risk of mistakes. That is all for our presentation. Retrospectively, hindsight is always 20/20, and if we had known what we do now about how services conduct their training, we could have specified our research, but at the time, this is what we thought would be beneficial. We want to thank you for taking the time to listen. If you have any further questions, please feel free to reach out to any of our group members. And we would also like to thank everyone that participated in our survey.
Thanks, Kayla. And thanks to your group for sharing your research. I think it was interesting to see some of the pieces that you got around people declaring that they were getting ROSC on every call and things like that. So there are definitely some interesting things come out when you survey people. We have two questions on YouTube for you. The first one is from Jen, and she asks, was there any differentiation in confidence levels between an adult cardiac arrest versus a pediatric cardiac arrest?
So that's a really good question. And it's funny that you asked that, because after we had conducted our research, we were like, it would be really cool if we would have done that. But we didn't. It was just strictly adult cardiac arrest. Okay.
But again, it proves the value of sometimes you get some results and you go, oh, actually there's another step forward we can do here. And that research leads to more research generally. And then Doug is joining us from Vancouver, and he's asked, was a confidence definition provided within the survey, or did you leave that at the discretion of respondents, like what you meant by confidence?
We left it up to the discretion of the respondent.
Okay, perfect. And you don't have a question from Justin, but he says, excellent presentation and great work.
Thank you. Thank you.
Any questions from within the class here on Zoom? No, this is just like teaching. All right, well, I'll leave you off the hook then. Thanks very much, and thanks for sharing your work. Good job. So ahead of schedule, and this is generally what happens, we kind of catch up on our time frames a bit. So we're about 10 minutes ahead of schedule at the moment. Next up will be Nicholas Robinson, Remo Ganai, and Nolan Weston, and they'll be talking about the effects of COVID-19 on paramedic students. So you're good to go whenever you're ready, Remo.
Hello, everyone. We're going to be presenting our presentation on our paper about investigating the effects of COVID-19 on paramedic students by myself, Remo, and Nolan. So just an intro. Over the past 2 years, it's become pretty evident that the outbreak of COVID-19 has had devastating effects on the society's mental health, fitness, and education. The purpose of this research study is to identify the overall effects of COVID-19 on future paramedics by evaluating current paramedic students. 12 paramedic students in the year 2 of the Fanshawe College's paramedic program answered 15 questions, which will be evaluated based on a systematic agree-disagree scale. The study revealed how COVID-19 pandemic has impacted the paramedic students' education, relationships, and health. So for our literature review, we reviewed 2 papers. First, from the British Journal of Psychiatry. It studied how COVID-19 has affected paramedics, and it found that paramedics have increased rates of depression, anxiety, fatigue, sleep disorders, post-traumatic stress disorder, and suicidal thoughts. Our second paper was from the Journal of Security, Intelligence, and Resilience Education. It also studied how COVID-19 affected paramedic students, and it found that students were very worried about contracting COVID-19, losing their jobs, loneliness, and depression.
So I'm Nolan, and I'll be going over the methods. We used a one-shot research design, which was 15 statements evaluated by a 5-point Likert scale. Third semester paramedic students, systemic agree, disagree, and we assessed 12 paramedic students. Next slide. So our study design was a descriptive cross-sectional study review, observational research. Participants are selected purely on the inclusion criteria of second-year primary care paramedic students at Fanshawe College. The study design chosen made the research cost-effective, quick to conduct, and suitable for descriptive analysis. Next slide. So our setting was second-year paramedic students from Fanshawe College, students in the final year of the program and are expected to graduate in 2022. The students participated in the study and shared their thoughts about the barriers of COVID-19 during their first and second years of the paramedic program. And our participants were 12 students. We only included second-year paramedic students because we wanted to have a snapshot of what our experience was like attending the program during the pandemic. We decided to exclude participants who may have already been enrolled in the program when the pandemic hit because we felt they would have a different experience than those who exclusively attended the program during the pandemic, as well as the first years who may have a different experience as well. Our procedures, we recruited students through Fanshawe online learning homepage of the paramedic program. We provided the consent letter and the survey on Google Forms to each student that was contacted. The sampling method we used was simple random sampling, where every student of the program had a fair chance to participate in the study. Consent forms were returned to the investigators via email, collected and stored in a secure file. The data is compiled into a Likert plot using computer software and then analyzed. Outcome measures. So we collected data using a survey consisting of 15 questions, 5-point Likert scale, and all questions are close-ended and have 5 possible responses, which were strongly disagree, disagree, neutral, agree, and strongly agree. And the data was measured using a Likert plot where we see how COVID-19 has impacted students positively or negatively.
Hello, my name is Remo, and I'll be going over the results. So this is a fraction of the questionnaire that was distributed to the 12 participants of the study. It's a systemic agree-disagree scale where participants answer to the best of their ability to all 15 questions. The data was then implemented into a stat column chart where data was further analyzed. So this is a stat column. Of participants find the pandemic to negatively impact their mental health throughout the school year. 75% of participants' motivation to stay physically fit reduced during the pandemic. 75% of participants' motivation in school was negatively impacted. 91% of participants feel more sluggish and tend to procrastinate more. 75% of participants have seen a decline in marks due to the pandemic. 50% of the participants have developed some sort of mental illness. 91% of participants found it difficult to maintain a social life. 80% of participants admit to spending more time on social media or streaming devices, and 85% of participants feel the pandemic harmed their overall well-being. So conclusion. Based on a study, we understand for the majority of the participants, the COVID-19 pandemic has caused students to procrastinate, have less motivation to stay physically fit, increased screen time on devices, a decline on mental health and personal well-being, and impacted their social life negatively. The limitations of the study is the number of participants of the study we understand is low, and results may be shifted. Although we do anticipate even with a higher number of participants, we would have similar and better results supporting the pandemic being a negative experience for many paramedic students. And that is the end of our study. Thank you very much for listening. And we'd like to thank our participants as well.
That's great. Thanks, guys. Thanks for sharing your work. And I think that more of these studies are needed as we go forward with regards to how COVID is after impacting people's learning. Because I know as educators, we're looking at it saying, you know, you're not getting the same experience as students from previous years who had probably more opportunities to be collegial and socialize together, and that can impact your socialization into the profession and things like that. So it's good to see people starting to explore that. And I think, you know, for yourselves, getting answers to questions that directly affect you. And I remember saying this at the beginning with the research stuff, is that, you know, there is a selfish component to doing research too, that you can ask questions that the answers will benefit you. And I mean you as a paramedic and you as a person, but then also us as a group, as a profession. So it's good to see people exploring that. I don't have any questions on YouTube for you right now. Is there any questions within the Zoom call here? Oh, actually, I do have a question on Zoom for you. So Justin has asked, what do you think might be influencing those findings between stressors in a healthcare context versus day-to-day pandemic life?
That's a really good question. Unfortunately, the only way to know is to ask them, right? But I think healthcare versus everyday life is probably very similar, just with the restrictions everyone's experiencing right now. You know, people have to wear a mask just like we do on every call, right? It's very similar, but ultimately at the end of the day, we don't know until we ask, right?
Doug has asked, did any of the results surprise you? I guess, were any of them things that you didn't expect to see when you went into this?
Not really. We kind of expected that, to be honest. Yeah, it wasn't really surprising, to be honest, in my opinion.
Yeah, I get this feeling that you were led to this research study based on your own kind of personal experiences, and
Yeah.
you wanted to see if,
100%.
I remember having that discussion with you. And Francis has asked, did you see a difference with outcomes with students who had more COVID patient contact as opposed to those with less? Did you investigate that?
We didn't investigate that, but I feel like the results would have been pretty similar.
Any questions within the Zoom call here for the group? I'm going to take it that you all just felt that way too, because it's your class that you actually surveyed, right? Yeah, so it's participants on this Zoom call. So yeah, it's definitely a challenge, and hopefully things will catch up with that. I know, you know, there are developments happening in paramedic education and in placements among services and stuff that hopefully will go some way towards addressing some of those stressors. And like, I would hold my hand up and say, as an educator, I think we struggled in a way to respond to the pandemic. You know, everybody was caught kind of on the hop and trying to respond to it quickly. And now that we're learning more about it, I think things will start to get a bit better. Jen has asked, was there anything that could have been done better to mitigate some of these feelings from like an education perspective, from our perspective in the college?
Just like the education, like feelings of like burnout and stuff like that, or?
Yeah, I think, you know, anything that we could have done to mitigate some of these results that you got.
Okay, yeah, well, I honestly don't think so. I think all the education staff did like amazing with the whole COVID-19 thing, adapting to online learning. I don't think that's ever been kind of done in that scale before, switching all classes to like online, everyone doing the best they can, right? I think what was done was pretty much as good as it could probably get with such short of a notice of doing such like a massive switch to virtual learning. I know there's been tons and tons of different like softwares and websites set up, like Noon, I think that's what we used, or Nearpod, my bad. Nearpod, that's a good like website for classroom stuff, for like activities and stuff like that. But I think overall, I think all the education staff did amazing.
I think that would be some bit of reassurance to us. John has asked, as a working paramedic, and so this is kind of progressing on from us as educators, as a working paramedic who will be working with new grads who felt these effects from COVID, how could he socialize you into the workplace? So is there anything that working paramedics can do to help you kind of address some of these feelings of, feeling isolated and perhaps not getting the same exposure to paramedicine the previous classes did?
I appreciate that question. Yeah. I think it's just really important to have an open mind, right? Because we have had less experiences as previous classes. Our education has been different from the other classes gone through this program. We haven't had the experiences that the students have had. So I think it's just important to keep an open mind, and if we ask questions that are kind of odd that maybe previous students would never ask, just kind of keep in mind that it's like, maybe we haven't experienced the things that we're supposed to experience yet, but we're very eager to become part of this profession, and we're just ready to start working, I suppose.
Yeah, that's great, Nick. Thanks because I remember going through your reflective pieces last semester in professional issues and making a post about that online, that, you're the COVID class. And I thought the interesting part was a lot of your reflections were that you were worried about the well-being of paramedics who've had to work through this. And that, that was one of your main concerns as a graduating class was, I hope the workforce are in a position to be able to support us, and I hope that they're all okay. And I thought that was interesting to see that in general, the whole trend was actually not towards how you felt yourselves, but towards the profession that you were going into and whether it was coping okay with this. So I think that'll go some way to show paramedics that, you are made of the right stuff and that you are thinking about your colleagues and things like that. But obviously, if they can provide support to you guys to actually help you to settle in and like you said, be aware of the fact that you may not have the same experiences, but you're trying. And I think that's important to get across. So I think great work. Thanks for sharing it. And
thank you, Alan.
Yeah, hopefully we'll, I do have one last question, if you can perhaps ask it there. So do you think using virtual scenario software would help address both Jen and John's questions? So I guess, do you see any value in using virtual scenario software?
I think it's definitely something to keep in mind. As the virtual software, as it keeps being developed and researched and improved upon, I'm sure it's going to get a lot better, more in depth, and just more of a good resource for students to use, right? Maybe the first generation iteration of this virtual software, has things to be improved upon, and that's to be expected because it's like the first generation, but
yeah,
as it keeps developing, it's going to get better just with student feedback and stuff like that. So I think even if it doesn't help the students now, most students should be partaking in it and, giving feedback to help the students that come on later. I think
I think Doug has made the point there that, this is the type of research that we need to keep reflecting back on and revisiting, in 2 years' time and in 5 years' time. How are you as the kind of first COVID class coping with being in the profession, and perhaps how has it changed maybe in response to the pandemic? So I'm not going to suggest that the three of you need to continue doing more research in this, but if there's any possibility of doing that, I think that there's a lot of value in not just leaving this go, but saying, okay, how has this affected people in their early career development? Because it's not just as simple as, we got our survey results and there's the answer. There is more to this as you go through the profession in the next couple of years. So yeah, great stuff. Thanks for sharing, guys.
Thanks again, guys.
We'll go to the last student group before a quick break. So next up we have Michelle Marco, Hannah Higgins, and Shuta Ando, who are going to speak about paramedic students' abilities to manage mental health or emotionally distressing calls. Over to you.
Thanks, Alan. I'll just set up the presentation here. Can everyone see it? Yeah.
Alrighty, so hi everyone, I'm Hannah. I'm one of the secondary investigators in this study. Today with Michelle, our primary investigator, and Shuda, our other secondary investigator, we are going to discuss our research regarding the perceptions of paramedic students in managing mental health and emotionally distressing calls. So just to give you an overview of what we're going to cover today, we're going to go through our background, study objective, methodology, our results, discussions and limitations, concluding remarks, and we'll have some time for questions at the end as well. So in 2021, the Canadian Mental Health Association reported that approximately 1 in 5 Canadians will personally experience a mental health problem or illness. During a mental health crisis or emotionally distressing event, paramedics are often the first to encounter the patient or individual, which places a high priority on the success of these interactions. In the pre-hospital setting, paramedics are placed in a unique position compared to other healthcare professionals due to the limitations surrounding our interventions that we can provide. With an increase in mental health related 911 calls, we wanted to investigate paramedic student preparedness in managing them. So next I'm going to pass it over to Michelle. She's going to cover our background, study objective, and our methodology.
Thanks, Hannah. So currently there is no literature or research directly related to our area of focus. We reviewed a total of 9 articles for this project and found that existing literature shows that paramedic students feel regarding emotionally distressing situations and stress on the job. It shows how they feel, but we don't directly know how prepared they feel to manage mental health crises and those sorts of calls. Current literature also provided insight into paramedic students' perceptions towards patients with mental health issues. However, the research within this area was predominantly conducted within the UK and Australia, which makes it difficult for results to be generalizable and applicable to Canadian paramedic students. And our study objective from that was to advance the understanding of how paramedic students feel regarding mental health crises and emotionally distressing calls, as well as their abilities to manage these calls. We hypothesized that paramedic students, with their lack of experience, will feel largely unprepared to manage these mental health crises and will recognize a need for additional education. So our study design, we conducted a qualitative focus group study of first and second year primary care paramedic students from Fanshawe College. We broke the participants up into focus groups based on their year of study, and due to COVID restrictions, we conducted it virtually using a Zoom platform. In total, we had 6 respondents, 4 first-year paramedic students and 2 second-year paramedic students. And throughout the focus group discussion, we facilitated it with 6 questions in total. Now I'm going to transfer it over to Shuda, who will go over each of our discussion questions as well as our all of our results. Over to you, Shuda.
Awesome. Thank you, Michelle. So as Michelle mentioned, we asked our participants 6 study questions to get an insight on their attitudes towards their abilities on managing mental health or emotionally distressing calls. The questions are listed on the slide here, and I will go through each one and discuss the findings in the upcoming slides. So we found connections and themes, and we identified them from the answers that we got to construct the results for this project. So the first question we asked participants to define a mental health crisis. So paramedics deal with various populations, and each patient encounter arises with a specific issue that is related to the presenting complaint. Mental health emergencies are commonly seen in the pre-hospital field, so it is important to be able to adequately be prepared to deal with these situations. To start, 83% of the participants defined the mental health crisis as a breaking point to which an individual is no longer able to cope with their mental illness and it affects their daily function. One participant stated that it is the point where one loses optimism and all feelings that arise are met with pessimism and negativity. Furthermore, 67% of the participants stated that the presentation of a mental health crisis is variable and relative between patients. For certain patients, it can present as a disinterest in activities, which normally creates feelings of enjoyment, or it can cause disconnects from relationships. In the same fashion, 67% of the participants expressed that mental health crisis can present with a wide range of symptoms. A mental health crisis is a relative term that can be defined in various different ways. As previously mentioned, the experience of a mental health crisis is variable between each patient. For our next question, I'm going to discuss the findings on what prepares one to adequately manage these situations. So as I said previously, our next question we asked was what best prepares someone to handle a mental health crisis? When it comes to the preparation for these emergencies, first and second year paramedic students both place higher value on practical experience compared to theory knowledge. So as you can see on the slide here, one of our participants states that they rely more on practical experience as not everyone presents with the same symptoms when they're dealing with a mental health crisis. As well as 66% of the first year participants expressed that strong mental self-care is essential in order to provide care for others. And as you can see from the second quote on the slide here, it says that the participant advocates for practicing this concept of self-care. So next slide, please. So next, we sought to investigate how education has helped prepare the participants to manage mental health crises. 100% of the participants reported having taken the mental crisis intervention course within their paramedic program. Participants from both years highly advocated for the value of the crisis intervention course and expressed that intervention course was a big resource and stated it was super helpful. As well, participants expressed a high value of the clinical placements done through their college education and appreciated the practical experience they got from those placement shifts. So moving on to the next question here, we asked the participants to get an insight on their perceptions of their own abilities to manage these mental health emergencies. So providing care for patients who are experiencing mental health emergency can come with different challenges as they are dynamic and they require different sets of skills for management. The participants in both the first and second years expressed uncertainties towards being able to properly manage mental health calls. 67% of the participants felt they are unable to manage mental health crises, as well as expressing a lack of confidence in being able to provide adequate treatment. Furthermore, a participant did feel they do not have the proper training to manage mental health patients and states they do not have the correct tools to provide effective interventions. The participants from both years expressed negative views on the perceptions of their abilities and states there are many unknowns within these situations. For the next question, we asked the participants if they believe paramedic students are adequately trained in managing mental health crises. We found that all participants from both years felt they were unprepared to manage these situations. First year students noted difficulty in answering this question due to where they are in the program and having limited knowledge on the future curriculum. Second year students attributed the lack of practical experience of feeling inadequate in managing these types of calls. However, all participants demonstrated optimism that by the end of the program, they'll have more training and experience and will feel better prepared when attending these calls. So for the last question, we asked about the stigma surrounding mental health patients. All participants agreed that the stigma surrounding mental health all participants agreed that stigma surrounding mental health are still prevalent today and can impact the care that the patients receive. 83% of the participants highlighted how their upbringing and personal experiences shape their own negative perceptions regarding mental health, and you can see that from one of the quotes on the slide here. All the participants brought forward a negative viewpoint that in the healthcare setting, mental health patients are often perceived as being uncooperative and unpredictable compared to other patients. Lastly, our participants also noted that there's a frequent association between mental health and drug and alcohol use. As our second quote highlights, this association demonstrates further bias and prejudice held towards mental health patients. Next, I'm going to pass it over to Hannah, who will review the discussion and the limitations of our project.
Thank you, Shuda. So based on our results, paramedic students clearly expressed not feeling adequately prepared in managing patients experiencing mental health crises or emotionally distressing events. Notably, second-year paramedic students reported greater exposure to mental health patients. However, they still felt apprehensive in managing these calls independently. All participants held greater value towards practical experience versus theory knowledge. Ultimately, all All participants expressed great interest in receiving more practical training so that they can provide better care to patients experiencing mental health crises and in turn strengthen their confidence. Regarding our study limitations, due to our focus group occurring virtually, participants were limited to those who had access to compatible devices and internet connection. Due to our small sample size of Fanshawe College paramedic students, our results are subjective to our participants and therefore cannot be generalized to all paramedic students. As well, our data is not representative across other healthcare fields as only paramedic students were recruited to participate. And now I'm going to pass it over to Michelle for our concluding remarks.
Thanks, Hannah. So to summarize, mental health crises and emotionally distressing calls have become more prevalent over the past few years and are projected to continually increase. Similar to our literature review findings, our focus group data showed that paramedic students do not feel sufficiently prepared to manage these patients experiencing mental health crises. Now, while paramedic students do admit to receiving some mental health patient care throughout their program, they ultimately believe that it isn't enough and argue that it should be further incorporated within their program. From this, we noted, especially during the focus group study, that participants expressed a desire for mental first aid and crisis training. So from that, we recommend that mental first aid and additional crisis training actually be put in place as prerequisites to all paramedic programs. And then ultimately, it brings us to the end of our presentation, and we'll take any questions if anyone has any here, but if not, we can always give, my email is just listed over here. And I just wanted to thank everyone for listening to our presentation. Hopefully you found some value with it.
Thanks, Michelle. Thanks, Hannah. Thanks, Shuta. So you do have questions already on YouTube. Thanks for sharing your work. I think it's really good to see people exploring this properly. We'll definitely take some of the recommendations on board and see if we can build them into, for example, in professional issues, when we talk about vulnerable and marginalized populations, that maybe some more resources there and accessing things like mental health first aid might be useful. So Justin has asked here on YouTube, well, first of all, he says, hats off to you for using focus groups and gathering qualitative data, that it's an ambitious approach. And I think we had a tendency in the paramedic programs up to a few years ago to very much focus on quantitative data. And so to see students, embracing qualitative approaches to data collection is good. But I think you'll agree it's not easier. In fact, sometimes it can be a bit more intense with the amount of analysis and things that you have to do. But he did ask, he's wondering if substance use came up in any of the focus groups during your discussions.
During the focus groups, not particularly. If anything, lightly, like we had in that quote there, just people's perceptions of other healthcare staff and their comments, but nothing specific about their own experiences with substance use.
Okay.
It's a good question, though, for sure.
John has asked, it was identified that participants were lacking tools. Did you come across any tools that would be helpful for paramedics in the field?
That's a great question. Off the top of my head, the only thing that I could really think of is the additional training, having the first aid as something under your belt before you even enter the program. Specific tools, I can't think of anything at the moment, but that is something that ideally would be offered during that course, I'd imagine.
Sure. Yeah, I think the targeted education addressing the shortcoming or the gap here it could be considered a tool for sure that would provide people with perhaps tools that they could use in their practice. So I think, like I said, I think that's a good recommendation. It's definitely one that we'll look at. Carly has said, thanks for sharing your work. Did you look at participants' self-perceptions of their own mental health history and any possible correlation on their confidence to handle mental health calls?
Yes, that's a great question. We actually did look at that a fair bit, particularly with our first focus group. Ultimately, what we found is that participants, when they didn't feel like they were at a good point themselves, they did not feel that they could also care for others. So ultimately, what they said at the baseline, they need to be at a good mental health point on their own before they can care for others.
And there's probably something there that if people have successfully managed a mental health crisis themselves, that they might be a bit more empathetic towards those who are having mental health crises. Because I know in the previous years where student groups have looked at empathy amongst paramedic students, the empathy is always lowest for substance use and mental health or suicide attempts. So there is definitely an issue there, I think, within the profession as a whole towards substance use and mental health calls. And yeah, there might be that piece that needs to be explored a bit more around empathy towards mental health patients when paramedics have had the experience themselves personally. Francis has asked, why do you think this topic is more prevalent now than in years past? And do you think it's because we're addressing it and that it's like a contemporary topic?
Great question. I think there's definitely that element to it. I think one other thing that we tried to explore within our focus group was seeing the effect that the pandemic has had, because everything has sort of been brought to the surface a bit more. Or at least that's the perception in the past few years. It could be a combination of things, but those two are the biggest ones that I would guess.
Yeah, I think I'd agree with that too. I think that a lot of, the stuff that we're dealing with as paramedics in clinical practice has changed over the years, and there's a realization of that now, and there's it's a topic of conversation and how that affects things like education and stuff. So yeah, I think it's multifactorial, I think, why these are now areas of focus, and plus probably realizing that we haven't done a very good job of it up to now, which leads into Niamh's question here on YouTube. She asks, interested to hear what the actual ratio of training or curriculum content to calls on the job is in mental health. So I don't know if you have anything from your study on that, but I can give some insight into curriculum.
I can't really speak for on the job training. Really, all that we could speak for is our own programs. We are still current students at Fanshawe. We didn't really highlight that didn't really get much from that in our focus group study. And sadly, I can't speak to the job part of that question. But I will say that within our program, if I were to guess, I'd say about 5 to 10% relative to scenarios when we do lab study practice is directly related to mental health practice or mental health patient care.
Yeah, and so one of the figures that it's not published, but a study that we did last year, where we looked at the data from a service here in Ontario, was about 2.6% of calls per year amongst a group of paramedics were to cardiac arrests, and about 5.4% of calls every year were to mental health crises. So you're doing twice as much mental health calls as a paramedic as you are cardiac arrests, and I can assure you, without looking at any figures, that you're not doing twice as much mental health education in the program as you are on cardiac arrest and resuscitation. Not that it has to be hour per hour on that ratio, but definitely there's a lack of acknowledgement of what paramedics actually do versus what they're prepared to do, and that's leading to some of the work that we're doing around redeveloping the NOCPs and things like that is an acknowledgement that perhaps the curriculum isn't fit for purpose and needs improvement. So last question for your group. So there's two pieces. One was, did participants mention any effect that the placements in Parkwood had on patient care experience? And the second piece then from Jen is, did you get any breakdown on age of participants in your focus groups, and if previous life experience had any impact on their perceptions of being able to manage mental health calls? So Parkwood and its impact, and then age and life experience.
Yes, so Parkwood was actually brought up a fair amount because that was the one clinical placement, or the one clinical placement with direct relation to mental health patients. And ultimately with Parkwood, the focus was on geriatric mental health patients. And while that was valuable, participants expressed that they would also have benefited from exposure to a younger group, just to see how that presents with different people of ages, and ultimately what that looks like and how they can better manage it. Just more exposure is what they were looking for. Because while the geriatric population was valuable. It's very different. It's very different how they go about their situation as well, like how they react, often due to a lot of immobility, and you can't move around as much. So it's a little bit different in how you would respond as well.
Sure, yeah, I think that's pretty fair to say. And then the second piece, just to remind you, was around age of your participants and life experience and its impact on.
So we didn't actually ask specifically their ages, but we did go into life experiences and how that help, or how they perceive that helps them with managing these mental health crises. And ultimately, the life experiences that we reported most during the focus group study was that they had previous education, so often pre-health programs, other programs, anything really that allowed them to have good communication skills and work on those communication skills. And then on top of that, really any interpersonal work that they would do with the public. So things from customer service or physiotherapy, any sorts of things like that, where they would actually be dealing with patients who may be in all levels of distress. It could be that they were happy or to the point of potentially in a crisis, depending on what was happening in that situation and how they would have to manage it. Just getting that exposure, talking to patients from like all walks of life, they found, or they reported that that's something that has helped them coming into this program, knowing how to talk to people, which is essentially most of your paramedic job, just knowing how to talk to people.
I would tend to agree with that. So yeah, and that's where I think a lot of the focus is moving in the education world now into the non-technical skills and how they're, we used to call them soft skills and think of them as extra things you develop on the side as well as being able to do trauma and resuscitation. But the reality is that they're the foundation to being able to do the job and most healthcare jobs. So not surprising that they shared those perspectives. So thanks for sharing your work. There was some really, really great insights there. You're getting some very positive feedback on YouTube. So it was a fantastic presentation and well done to all of you. So at this point, we'll take a break. We're 10 minutes ahead of schedule. So you get a longer break, which was what the intent was. So we're at 10:30 according to my clock here. So we're back at 10:50. That's a 20-minute break. The link stays the same. So if you're on YouTube, you have 20 minutes to take a break away from the computer, and same for everyone on the Zoom call. And we will return back here at 10:50 with the first student group, which is Lauren Conrad's group, who are looking at studying habits in paramedic students. See you then. Okay, welcome back, everyone. I'm going to go straight into the next student presentation. I misspoke before the break, and it's not Lauren Conrad's group. The next up to talk to us is Prasanthi Mahendra Raja, who's going to present on the impact that exercise has on police and paramedic students' GPA. So over to you, Prasanthi.
Hi, everyone. I'd like to first thank everyone joining me here today this morning. My name is Prasanthi, and I am the principal investigator for this research presentation. And the research project I'll be discussing today is the impact of exercise on first responder student GPA. So the agenda for today, I'm going to go over some background information, and then we're going to debrief some of the literature review that I've reviewed itself. And then we're going to dive into the research by discussing the methods, the data, the results, and then some limitations will be discussed in the discussion piece, and then we're going to conclude and wrap up the entire presentation. So we're going to first start off with the background information. So to begin, let's take a look at the brain. The brain has a critical development period, which starts at the age of 2 and ends at about the age of 7. So within the critical development period, a child's mental, physical, and psychosocial health develops, which impacts cognitive, academic, and physical performance. So activities such as gym, subjects such as math, they're all meant to stimulate the brain's working memory and develop those aforementioned areas. To have this period continue on for the majority of our lives would be super beneficial. However, unfortunately, it does plateau beyond the age of 25. And as a result, it becomes difficult for people beyond that age to easily learn new concepts or to pick up new activities without much effort. So a hobby of interest, however, can stimulate the brain's mental, physical, and psychosocial health, and this positively impacts cognitive, academic, and physical performance. So the reason that I bring this up is because a number of research performed on post-secondary students found that exercises, more specifically aerobic exercises, had a positive impact on our cognitive functions, which as a result impacts our academic performance and increasing the academic performance itself. And as a result, with such findings, it can be said that based off these past researches that a positive correlation does exist between students who exercise and increase academic performance. So this has led to our team's research question, which was that, is there a relationship between embedded physical fitness programs and academic performance in primary care paramedic and police foundation students? Just to quickly give you an overview, if for those of you who do not know, in both the Police Foundation and the Primary Care Paramedic programs, they do have a physical education component to it, and that's what we're referring to in this question about embedded physical fitness programs. So we're looking at outside of that program, like their physical activity levels. So we're next going to go into literature review. So before the research question could even be answered, a better understanding had to be developed with respect to the question itself. So 8 different literatures were reviewed, 1 conducted on children and 7 conducted on post-secondary students. And as we can see on this slide, about 6 of the 8 studies, or about 75% of the literatures, found a high correlation between students who had an exercise routine and increased academic performance. And 2 of the 8 studies, or so about 25% of the studies, found a moderate correlation between students who had an exercise routine and had increased academic performance. So upon examining the literatures, which found a strong correlation between students with an exercise routine and increased academic performance, a few key points were found. So students who studied exercise, at minimum 20 minutes a day, 3 times a week, and had an exercise routine which contained a vigorous physical activity such as aerobic exercises, were likely to achieve a GPA greater than 80%. So it can be said that if the student rigorously followed their exercise routine, then there is the possibility that they were disciplined in their studies as well, as they're more than likely to adopt a study routine and follow it. With that said, it became really important for us to understand whether such finding was in fact true, and that's kind of what led to our research question today. So we're going to go on to the research methods. So the performed research had a quantitative longitudinal research design, and it examined the students' study and exercise routine over 3 different time periods. So before being enrolled in the first responder program, during semester 1, and during semester 2, the first responder program. The primary research phase consisted of an online questionnaire, which is conducted over Google Forms, and it contained about 4 sections and 22 closed-ended questions. The 4 sections were broken up into socio-demographic data, and then sections 2 to 4, it more so examined before being enrolled in the first responder program, during semester 1, during semester 2, first responder program. The data collection period before it even commenced, we did receive research ethics approval from Fanshawe College, and data collection period started on May 1st and concluded on August 31st, 2021. So the students, for them to participate in the study, we primarily focused on primary care paramedic and police foundation students enrolled in Fanshawe College's London campus between the years of 2019 and 2020. And this also included students who were already within the program. They were also allowed to be participating in the study, regardless of the level of education they were in. So if they're in level 2 of the program, they were still allowed to participate in the study during that time period. These students who were not allowed to participate in the program in this research study were those who were disqualified from the program or those who voluntarily withdrew from the program itself. So next, we're going to talk about the data. So before the study was conducted, we estimated that sample size would be about 80 students, and that was our expected population that we were expecting to analyze at the end of the research. After the data collection period was completed, the actual sample size panned out to be 20 students. However, 3 of the students' results were invalid because they did not provide consent. So we were left with 25 of the 20 responses for analysis. So this provided our team with a 31% response rate. Of the 25 responses, 60% of the students were enrolled in the Police Foundation program and 40% were enrolled in the Primary Care Paramedic program. To examine all the collected responses, a frequency analysis was used, and this helped us determine the central tendency of the variables when examining the relationship of the different variables to one another. So through this research, we wanted to determine whether one of our 2 hypotheses were true. So either our null hypothesis was correct and students with an exercise routine outside the embedded physical fitness programs had a GPA greater than or equal to 80%, or our alternative hypothesis was deemed to be true, whether there was no correlation between students who had an exercise routine outside the physical fitness program and a GPA greater than 80%. So we're going to next go into our results. So as previously mentioned, we have distributed the questionnaire. So the distributed questionnaire received about 28 responses, and we already know that 3 were excluded from analysis due to consent not being provided. You can see that shown in the gray over there at the top left corner. And this left us with the remainder of 25 responses. So 10 of those responses included primary care paramedic students. So they are represented in the orange on our screen here. And then 15 of the responses were from Police Foundation students, which are represented in green. And to look at it a little bit deeper into that, specifically focusing on the primary care paramedic students, about 40% of the respondents are males and 60% of the respondents are females. And we look at the Police Foundation students, about 53% of the respondents are males and 47% of the respondents are females. So the main question is, how do we know whether someone is considered to be physically active? Well, according to the Canadian Physical Activity Guideline, at minimum 150 minutes of exercise is required per week to be considered physically active. So if we look at the chart before us, we can see and determine based off the questions that the students have answered in their questionnaire with respect to exercise duration and exercise frequency, determine who was actually considered to be physically active. So on this chart, we can see going across the rows, we have exercise duration, and then going down the rows, we have exercise frequency. And the way we determined whether or not someone was considered physically active was that we took the higher number of the limit of the range that we had. So if we're looking at an exercise duration of 0 to 30 minutes, the question originally posed less than 30 minutes was one of the options. So we would look at 29 minutes, and then if we're looking at 1 to 2 times a week of frequency of exercise, we do 29 minutes times the 2, and that would give us our exercise duration for the week. And so with that being said, the boxes that are shaded in green indicates the exercise frequency and duration that equated to more than 150 minutes or greater than equal to 150 minutes exercise per week. So keeping this chart in mind, we found that of the 25 students, 17 students were considered to be truly physically active. However, unfortunately, because our sample size was very small, we decided to keep all our respondents' answers within the entire analysis. So to break down what I just mentioned earlier, we have 25 students in semester 1 and semester 2. Of the 25 students, we know 16 met the Canadian Physical Activity Guidelines in semester 1, and 17 students met the Canadian Physical Activity Guidelines in semester 2. And in semester 1, so about 8 students were primary care paramedic students who met that guideline. And in semester 2, about 7 students met that physical activity guideline who are primary care paramedic students. And then with Police Foundation students, we know that about 8 of the Police Foundation students met that physical activity guidelines in semester 1. And in semester 2, about 10 of those Police Foundation students met that physical activity guidelines in semester 2. So before we can analyze the data, I'd like to go over what we defined as a positive relationship. So a relationship between the examined variables is considered to be positively correlated if it has the highest frequency count over 2 time periods. So we're looking at semester 1 and semester 2 for all our variables that are being analyzed. So if the examined variables have the highest frequency over 1 time period, so only in semester 1, but not in semester 2, and vice versa, then this is not considered a positive relationship at all. And as we progress through the different variables that we'll be examining, you'll kind of understand why this was done, and it was more so for the ease of understandability and for simplicity purposes. So with that said, the first relationship that will be examined is exercise frequency, study time, and GPA. So in front of us, we can see a chart from semester 1, and we can see that 9 students who exercised between 5 to 6 times a week and had a study time greater than 60 minutes earned a GPA greater than 80%. This was the highest option that had the highest frequency response for semester 1. The same relationship was examined in semester 2, and that showcased that the highest frequency responses were seen in students who exercised with a frequency of 3 to 4 times a week and studied for more than 60 minutes a day. So given these discrepancies and what we defined as a positive correlation, it can be stated that there is no relationship between exercise frequency, study time, and a GPA greater than 80%. The next relationship that will be examined is exercise duration, study time, and GPA. The variables that received the highest number of responses in semester 1 was an exercise duration of 30 to 60 minutes and a study time greater than 60 minutes, with a frequency count being of 9 responses. In semester 2, the variables that received the highest frequency was the same as semester 1, so with an exercise duration of 30 to 60 minutes and a study time greater than 60 minutes. And these variables received a frequency count of 10 responses. So with that being said, we know the category with the highest frequency count was a 30 to 60 minute exercise duration category and a study time greater than 60 minutes. So on our screen here, we can see that this solely focuses on the exercise durations. So we can see going down, it says less than 30 minutes that's being represented, 30 to 60 minutes being represented by that middle category, and then greater than 60 minutes exercise being represented by the final category down there. And we have semester 1 and semester 2, and we're comparing the study time greater than 60 minutes in this slide specifically. So with that being said, to the left in semester 1, we can say that about 36% of the students, and in semester 2, which is to our right, about 40% of the students who had exercise duration between 30 to 60 minutes and a study time greater than 60 minutes achieved a GPA greater than 80%. So this demonstrated that there was a 4% increase in students who achieved an increased GPA within those variable parameters. So this showcases that there is a positive relationship between exercise duration, study time, and GPA. The final relationship that will be examined is exercise type and GPA. The chart in front of us shows 3 exercise types, so muscle strength-based, cardiovascular, and aerobic exercises. These 3 exercises are side-by-side examined over semester 1 and semester 2. So as we can see, the exercise types that had the highest frequency count were over the 2 semesters were muscle strength-based and cardiovascular exercises. Just to let you guys know, these questions were a multi-select response. So students who felt like they had multiple of these exercise types incorporated in the exercise routine, they're allowed to choose whatever they felt existed in that routine of theirs. So multiple responses were permitted for this question itself. So we can see that in the muscle strength-based exercise, we had 17 responses in semester 1 and 19 responses in semester 2. And then in the cardiovascular exercises, we had 16 responses in semester 1 and 19 responses in semester 2. And these are for the higher parameters of getting a GPA greater than or equal to 80%. So both of these exercises, we can see they had an increase in frequency over the semesters, and these variables were seen to be correlated with students who achieved a GPA greater than 80%. So when we look at the number of exercise types each student participated in, the options were split between one exercise type or two or more exercise types. So we can see that represented by each role. And the highest frequency was found in muscle strength-based and cardiovascular exercise, as we already know. And we know that in semester 1, about 60% of our students participate in two or more exercise types. And we had a 16% increase within that time, making 76% of students participating more than two or more exercise types in semester 2. So this can include being muscle strength-based and cardiovascular exercises, or it could be muscle strength-based, cardiovascular or aerobic exercises. So this, based off of these charts, we can see that there was a positive correlation between exercise type and GPA. So next thing I'll be discussing is a discussion piece, which I'll be discussing more of the limitations. So our research had a few limitations. The first limitations was data and statistical limitations. The team initially intended to do a statistical analysis on this. However, to properly analyze the relationship between various variables, it was not feasible at this point because our sample size was so small that a statistical analysis would have skewed our results and would have not provided an accurate relationship representation. So instead, we decided to opt for the frequency analysis. The second limitation that we had was the data collection period. So data collection period occurred over the months where students were not enrolled in school. So as I said before, it was from May 1st to August 31st, 2021. So students in this case, they may have access to FOL email on a limited basis, or where they probably just missed the research invitation because it was sent out to students through email, to their FOL email, or they may have just viewed the invitation after the entire data collection period had concluded. And then the final limitation was the factors related to study time. So the only variable that was analyzed for our study was study time. And now that we know study time has an effect on student GPA, it would have been better to explore other factors associated with the study routine and the management of their time to better understand what in particular differs in students' daily or study routine that results in an increased GPA. So these were some limitations that if researchers decide to replicate in the future, they can take this into account for consideration if they decide to replicate the study once again. So the final thing we're going to be discussing is a conclusion. So despite these limitations, we were able to gain new insight with respect to our research question, which was, is there a relationship between students who have an exercise routine outside the embedded physical fitness program and academic performance in police foundation and primary care paramedic students? So given the number of students who we deemed physically active with respect to Canadian physical activity guideline, we know that about 68% of the students were considered physically active. We also know that about 60% of the students had a GPA that was greater than or equal to 80%, and they had an exercise routine that lasted about 30 to 60 minutes in duration. It had more than two or more exercise types, and they studied for more than 60 minutes a day. We knew that exercise frequency and GPA had no correlated effect on one another, which contradicted that of past research, which did in fact suggest that an increase in exercise frequency would result in an increased GPA. And not only that, we also know that with respect to students who participated in, they said that like students who participate in aerobic exercises were likely to achieve a GPA greater than 80% due to being able to stimulate that cognitive functioning and increasing that working memory in our brain. But through our research, we found that students who participate in muscle strength-based and cardiovascular exercise at minimum had a higher correlation with a GPA greater than 80%. Something that we could take into fact was that we're focusing on students who are enrolled in a first responder program, and these two programs heavily rely on the two exercise types to become physically fit for duty. So nonetheless, no correlation existed from our research between students who claim to be physically active and a GPA greater than 80%. And what other factors include, we can see that students can benefit from an increase in exercise types and an exercise duration greater than 30 minutes and a study time greater than 60 minutes. So as a summary, I went over the background information, we discussed some literatures, and then we went over the research itself, and we just concluded presentation. I'd like to thank everyone for joining me here for my presentation today. And if you have any questions, feel free to reach out to me, the Principal Investigator Prasanti, through this email. Thank you.
Thanks, Prasanti. Unfortunately, we don't have time for questions for Prasanti's one in order to give the other groups their time. But there's one quick one, Prasanti, that you can maybe answer is, did the subjects use a time log, or was it just a self-reported estimate of time that they were?
So is it for the study routine or the exercise?
It says, did you, how was participation time in exercise and studying tracked? Did they use a time log or just self-reported estimates?
Yeah, so all the students, they had to report it. So they were given, so for all the questions for exercise duration and study time, they were given 3 options. So less than 30 minutes, 30 to 60 minutes, or greater than 60 minutes of exercise or of study routine.
Yeah, so did they track, was it just their estimate on that?
It was their estimate, yes.
Okay.
So they estimated that was their approximate time on each one.
Perfect, thanks. So yeah, the rest of the questions, we can maybe get to them in the next break. But right now I'll hand over to the next group. So Lauren Conrad and her group are going to talk about studying habits for paramedic students. So over to you.
Just wait for the slideshow to come up. All right, so hello everyone. My name is Lauren Conrad, and today we're going to be discussing successful studying habits for paramedic students. Speakers you'll be hearing from today are Kyle, Kevin, Zachary, and Alexis.
Okay, so for our group project, we decided to research study habits and time management strategies of recent graduates of the Fanshawe College Paramedic program. Using a qualitative approach, our candidates were invited to participate in an interview where they were asked a series of questions. The interview involved questions that focused on the students' study habits, time management strategies, and their own perceived level of success. Following the interviews, the candidates' answers were analyzed, and our group determined if there was a correlation between certain methods and the student success. We originally hypothesized that the graduates who have developed exceptional study habits and time management skills will view themselves as having been more successful than those who did not develop efficient skills. We decided to explore this topic because throughout our time as paramedic students, we quickly learned how challenging this program can be. We believe that by conducting this research, we can help future ambitious paramedic students by exposing them to study habits that are proven to be beneficial. The hope is that these students will not only be more successful throughout the program, but will also perform better when they enter the profession. When conducting our literature review, we noticed that there's a lack of research regarding the paramedic program specifically. Most of the research that's been done in the past focuses on students attending school for in-hospital occupations such as nursing. Although this research can be helpful, the paramedic program differs greatly from in-hospital care. Therefore, research specifically directed towards the paramedic program needs to be done. Not only will this benefit students, but also services in the future because they will be receiving more competent graduates. Throughout this presentation, we will discuss our literature review, our study design and methodology, as well as our results and data analysis.
Yeah, so as Vanessa just kind of said, there's quite a lack of research on this topic to do with paramedics themselves. So we actually reviewed 6 studies before we carried out our research and found that none of those studies actually related to paramedics. So it kind of confirmed to us the necessity of our research. And again, as Vanessa said, it was generally involved nurses and medical students. These studies, just like ours, were generally qualitative studies, and they were more subjective about the students' experiences and their study habits. They focused usually, the one study found that there was a correlation between procrastination or poor study habits and students' higher stress levels. That study unfortunately was not able to determine a direction of causation, meaning it wasn't really clear whether the procrastination was causing the stress levels or the stress levels were causing procrastination. Another study found that there was an association between stress levels and potential negative consequences. So when there were assessments that had to be done, so exams and stuff like that, students' stressors were obviously higher. That same study also found that some students that had a previous post-secondary education actually had an advantage, though, over those that did not. And then another study that we had basically stated that student study habits were dependent on how directly that course related to their program overall. So if it was more of a science-based course in the case of medical students, they would put more effort into those classes, into studying those content, those subjects, sorry. So yeah, for example, like in that case, they were able to differentiate between the relevant courses to the program versus not. And then as far as study habits themselves goes, obviously there's a range of study habits from simple to more complex. So in one of these studies, it was more just studying in groups and quizzing each other, cue cards, things like that were very beneficial. Whereas other ones, like medical students, they preferred more complex study methods that were better for long-term information retention and focus on a deeper understanding for longevity of that information. And that's.
So our targeted population consisted of active paramedics who had previously graduated from the Fanshawe's PCP program within the last 10 years. Besides this, there was no other exclusionary criteria for the study. We decided on this criteria for two reasons. One, because it helped ensure that the program didn't change significantly, and two, to keep our results relevant to future classes. We had a total of five participants, and they all graduated within the last 8 years. We opted for a smaller sample size because based on recommendations from our project supervisor, and this also helped keep our research more manageable since we were doing really thorough interviews. The study itself was qualitative in nature, using a semi-structured interview design. We felt that a more informal interview process would allow our participants to provide us with more real-world answers. And based on our research question, we developed a total of 17 interview questions. If you take a look on the slide, there's a few examples on the right. These questions were designed to elicit detailed responses regarding things like personal study habits and how these habits correlated to their own perceived level of academic success. Participants also had the opportunity to expand on these questions, and when needed, prompting questions were used to elicit more detailed responses. The interviews took place over Zoom video conferencing, and they lasted about 30 minutes each. Each interview was recorded so that our group members would be able to analyze the participants' answers later on.
So before moving forward with our research, we submitted an ethics application to the Research Ethics Board of Fanshawe College, and it was then approved. Each participant before being interviewed was provided with a consent letter prior to their participation, just to allowing them to understand their involvement. Also, we explored all potential conflicts of interest, and there were none of note. So after all 5 participants were interviewed, we examined the data for correlations between each of the participants' responses to identify themes or patterns, and here is what we discovered. It was found that graduates most often used an agenda, calendar, or list to keep track of due dates. This allowed them to stay organized and on top of the workload. Participants stated that they would study ahead of time for testing at least a week in advance and avoided cramming for examinations as much as possible. Most participants estimated their time commitment to school-related activities to reach around 40 to 60 hours per week. This did include scheduled class times. Participants also stated taking 15 to 30-minute breaks every 45 minutes to an hour to reset their focus was beneficial to their studying, allowing them to retain more information. All graduates stated setting small goals for themselves during study sessions would also allow for more work to get done. One example from a participant was not leaving the room until they finished reading a chapter. With such a heavy workload at the time, the participants' highest priority was their education. It was found that exercise, sleep, and social lifestyles came second. When it came to preparation, participants would either print lecture notes or read the course material before classes, allowing them to have a general understanding of what is to be learned that day. That would allow for greater retention of knowledge and mitigated the time and energy to revisit those topics. When studying notes, the notes were then divided into different sections, for example, pharmacology, patient care, and anatomy, physiology, and then they would separate those notes accordingly. Graduates found studying in groups was also beneficial to their preparation, as they would quiz each other and make practice questions. To prepare for scenario testing, graduates would run through scenarios physically and verbally with their peers, whether it was during extra lab times or on their own study sessions. Every participant stated that this study method was extremely beneficial for their learning. And then when participants were asked if they felt prepared for tests or exams, they all answered yes. So now moving on to class habits. Graduates attended most classes, if not all, and enjoyed instructor-led classes rather than self-directed tasks. During class times, they would actively take notes and participate during class as much as possible. It was also found that there was no correlation between concentration periods. The participants had a wide range from 30 to 40 to 1 to 2 hours of concentration. So it just really depended on the student. When asked about additional resource use, participants identified that they used online school resources, reached out to instructors for extra help, and used Google at times. A textbook was not widely used, as only one participant used this resource. Most participants said that the lecture slides and course material given was all that was needed to grasp the content. For self-preparation, participants were satisfied with the grades they all received. They found that their study habits and the good relationships that they built with their instructors was pertinent to their academic success. And then we also asked what the most important aspect in being a successful paramedic graduate was, and they all answered with time management. Putting in the time to study.
Just to let you know, Lauren, your mic has stopped working.
Oh, can you hear me now?
Yeah, there's a lot of noise, so just to be aware.
Oh, sorry. Did you hear everything I said?
You just lost the last sentence there if you want to go back to it.
Oh, the last sentence? Okay. So I'll just go over the last part. So we asked all of our graduates what the most important aspect of in the program was, and they all said time management. Putting in time to study, work hard, and organize their schedule would set them up for success in the program.
So now we're going to move on to discussions and implications. So after reviewing the data that we collected through our interview process, a couple common trends were identified between our participants. However, there were a few differences as well. For example, most of our participants credited their class participation to have a lot to do with their success and knowledge retention. However, we did have one participant who expressed that they preferred to stay in the background and, as they described, absorb what they can in the moment and take any questions that they have later and try to figure it out for themselves. A couple other examples like this are recorded in our research, and it shows that there's multiple ways to be successful. It's just dependent on the student. For example, like behavior during class time, note-taking, time commitments, and so on. You just have to find what works best for you. You can still find an equal amount of success as another person based off what works best for you. No study strategy guarantees success, and the amount of effort you put forward changes your results. To build off this last point, most participants described that finding your own way of doing things, that really is what kind of tailored their study habits to them. Moving on to implications. There's a couple practical implications that my team members and I noted potential for. The first being introducing popular study habit concepts to students beginning the programs, just as frameworks proven to facilitate the success of other students. Students who enter the program with less experience as well, compared to somebody who has post-secondary experiences, might find it helpful if their program instructors highlight some strategies to time manage effectively in an exceptionally busy program like this one. Our research also can hopefully shine some light on the field of paramedicine, and more specifically, paramedic students as an area that could benefit from more research. We hope that this research continues the discussion of study habits and what makes a student successful, as well as promotes future paramedics to engage in continuous education by simplifying their studying and research experiences. Objectively speaking, our program is rather difficult, and it'll only get busier as the PCP scope continues to expand, so this topic will only become more relevant in the future.
All right, so I'll be talking about the limitations of our study. So we were able to uncover a few of those. The first of which was the sample size of the study. So obviously, when you have a sample size that small, it's kind of hard to state that the research is going to be applicable to a wide variety of people, especially when we're looking at students across Canada. So if we had the chance to do the study again, I think that'd be a good starting point, is try to include more participants and expand on our data. The second one is obviously the fact that this is a qualitative study. There's a great deal of subjectivity that can be introduced into it by our participants. Obviously, that allows for some biases. So when we start to look at, people's evaluation of their own performance, most people tend to have a pretty good opinion on how they performed in school. So it kind of it allows for the introduction of that. So we think going forward, if we were to do this again, like I said, having some sort of quantitative measure in there to kind of provide validity to their claims, such as a transcript or something like that, may be important. And then the last thing as well that we kind of talked about was the fact that the demographic of our participants were all very narrow, which was good to start with. But if we're going to start to look into how our research can affect a wider variety of people in the paramedic profession and in the programs, we should try to expand on that. So we had all of our participants were all PCP recent grads within the last few years from the same school. And that becomes very limited in nature, right? So there's obviously, it's probably safe to say that there's a lot of cultural differences between schools and provinces that are in the paramedic programs that we cannot possibly account for in our research. And there's also probably a wide variety of learning outcomes as well if we're looking at schools that don't follow the NOCP accreditation. So I think expanding the research into to include ACPs or CCPs as well in the future would help to kind of give validity to our claims and assist us in helping paramedic education past the PCP graduation. You can go to the next slide there. All right, so in conclusion, we were able to prove our hypothesis to the extent that was possible given the study that we designed here. So the 5 participants and the research we did was great, and we did prove our hypothesis. However, I think there's a lot more research that can be done in this area to not only further prove our research, but give more opportunities to disprove our research as well. So like Zach said, we hope that this can provide some insight and benefits in the future for paramedic students going through not only Fanshawe, but other programs as well. And again, as I mentioned before, further research is definitely recommended for this topic, much like many others. So yeah, Lauren, if you want to polish her off there. Your closing remark.
I apologize for my mic if it's not working properly, but we would like to give acknowledgement to participants that volunteered their time, and we would also like to thank Professor Alan Batt for the necessary knowledge, feedback, and guidance throughout the course of our research. And finally, thank you for everyone for listening to our project.
Thanks, guys. We do have a question here for you on YouTube. So Wayne asks, did the participants identify their own personal strengths and weaknesses prior to determining the best approach in identifying the best study habits for their success? So did they identify their own personal strengths and weaknesses?
No, they did not. I know, well, actually one participant did. He said that he found that he did post-secondary like before entering the paramedic program, and he said that he found like working in groups before ended up distracting him, so that's why that one participant would end up just studying alone.
I don't have any other questions on YouTube right now. Any questions from within the Zoom call for this group? So while we're just waiting for another question perhaps to appear, I just want to say thanks for taking on a topic like this. It's not, I know people are normally interested in things that are kind of clinical practice and things that are going to help you, be a paramedic, but the reality is that quite a large portion of you are going to continue on with education, may go back to higher education in the future, and actually looking at things like how we can support successful study habits is a big piece, especially with some of your findings. I think, the move towards the self-directed, a lot of it is self-directed now. I think you're definitely experienced in that Fanshawe is very much you kind of learn this yourself and we'll provide the structure. And that there are students who that's a challenge for, and, we need to get the balance right on that. And it is a struggle from year to year to see where the balance fits. But I think the research that you've done is a good example of when you give students the appropriate tools and the resources that they can self-direct their learning, and like you produced a great study here, I think that has a lot of useful information. So I guess it's a point proven that you are actually able to do this, and just want to commend you for that. So well done. Thank you very much. So we'll move on to the last group before our next break. So Gilwan Amini and his colleagues are going to speak about paramedic student personality traits and self-perceived career choice satisfaction. So over to your group, Gilwan.
All right. Good morning, everyone, and thank you for joining us today for our presentation on our research into the correlation of student paramedic personality traits and their self-perceived career satisfaction and success within the program. This investigation was conducted by Gilwan Amini, Justin Coverdale, our primary investigator, Jad Hakeem, and myself, Justin Williams. To begin, the objective of our research project was to develop an average paramedic student personality profile based on the 5-factor model, since the literature we reviewed produced inconsistent findings in working paramedics. We then compared the student personality profiles to the students' self-perceived satisfaction within the program through a questionnaire created by our group. Using the possible correlation between our data sets, we wanted to see if the implementation of a personality profile could be used as a possible career choice guide at the beginning of the program that could help students better tell if the program is right for them. Next slide, thank you. As you can see, these are the 5 traits that we based our student personality profiles on. Oftentimes, intellect and openness, as well as emotional stability and eroticism, can be used interchangeably, but make minimal changes to the end result. Next up, we'll have Gilwan talk about our research into previous literature and further detail into the methods in which we conducted our research.
My name is Gilwan Amini. I'll be discussing our literature review and our methods for obtaining our data. We conducted a review of 8 studies from the literature that examined paramedic personality. Our goal was to find notable patterns of paramedic personality traits from any study that employed a measurement of the FFM or the 5-factor model. Some notable data that was a study done in 7 Australian universities with paramedic programs found females to score higher than males on empathy. But what was interesting is that empathy levels decreased as students progressed in the program. They also found that empathy levels in paramedicine were among the lowest among all healthcare fields. Another study was done on 395 paramedics, found that paramedics showed increased levels of resilience and lower levels of stress compared to other healthcare professionals. This shows that though empathy levels decrease as paramedics progress in their careers, their resilience levels increase. When relating to the 5-factor model on personalities, we found multiple studies that showed data correlating resilience and improved abilities to deal with stress with emotional stability and conscientiousness. Among these studies, it showed that medics with a family life scored higher on extroversion, conscientiousness, intellect, and agreeableness than other healthcare professionals. Many studies that use the 5-factor model when assessing personalities among healthcare workers and concluded a heterogeneous population among healthcare workers. But when it comes to students, it resulted in a lot of inconsistency and non-definitive personality profiles among students. We conducted a questionnaire-based quantitative analysis on 16 first-year and second-year paramedic students from the Fanshawe College Primary Care Paramedic Program in London, Ontario, Canada. Inclusion criteria consisted of active status in any paramedic program. However, we only recruited students from Fanshawe College only. The questionnaire was completed as an online survey through Google Forms. For our recruitment strategy, we used Facebook and direct emails to obtain our research participation. To collect data describing the personality of our participants, we administered the 50-item International Personality Item Pool, or IPIP questionnaire. The IPIP questionnaire consists of 50 statements which participants may respond to by describing how accurately the statement describes a personality. The 50-item IPIP is one of many methods of assessing the Big 5 personality traits. The Big 5 personality traits are extroversion, agreeableness, conscientiousness, emotional stability, and intellect. The questionnaire gave each participant a numerical score for 5 different personality traits. Questions were added that would obtain our participants' self-perceived performance and satisfaction in the paramedic program, so we could obtain any data resulting in any self-perceived performance in the program being correlated with any of the traits.
Hi, my name is Justin Coverdale, and I will be discussing the results from our research. On average, paramedic students score higher on agreeableness, conscientiousness, and intellect than did random students from various American colleges. Both paramedic students and other student groups scored the same on extroversion and emotional stability. Therefore, we conclude that paramedic students score high on agreeableness, conscientiousness, and intellect as compared to a random population of university and college students. Next slide. We compared our participants' score on the 5 personality domains with the score on self-perceived satisfaction in the paramedic program to look for any correlations. We did this by calculating a correlation coefficient between the data set on each of the 5 personality traits and the data set on self-perceived program satisfaction. A correlation coefficient score of 1 indicates a positive correlation, a score of -1 indicates a negative correlation, and a score of 0 indicates no significant correlation. Extroversion and agreeableness scored 0.0922 and 0.183 respectively, which indicates that these traits have no significant correlation with self-perceived program satisfaction. Conscientiousness, emotional stability, and intellect scored 0.401, 0.527, and 0.58 respectively, which indicates that they are positively correlated with self-perceived program satisfaction.
After compiling our results, we looked to find any notable patterns. And as you can see here on the slide, this was the main pattern that we noticed, which was that paramedic students scored high on agreeableness, conscientiousness, and intellect as compared to other students, which also took the same personality questionnaire in various universities from the United States. And so from this, we concluded that paramedic students scored high on agreeableness, conscientiousness, and intellect. And when it came time to compare this data with evidence from the literature, we found that for the most part that the literature had inconsistent results across multiple different studies, But there were some notable patterns, specifically that paramedics and paramedic students tend to score high on conscientiousness and emotional stability, and that high scores on those traits is associated with increased resilience and better coping mechanisms to stress. So our data matches with the evidence from the literature in that we also found that paramedic students scored high on conscientiousness. However, the high scores on agreeableness and intellect did not match with data from the literature. Also to note is our results on extroversion and emotional stability indicate that paramedics score about the same as the general population, whereas evidence from the literature indicates that paramedics tend to score higher on emotional stability. The second part of our analysis and patterns was regarding self-perceived career choice satisfaction. So as you can see in this chart, when students score high on conscientiousness, intellect, and emotional stability, they also tend to score high on self-perceived career choice satisfaction. So from this, we can come to the conclusion that those personality traits are associated with high program satisfaction and an overall positive experience in the paramedic program. One thing to note is self-perceived career choice satisfaction is based off a 10-question questionnaire. And this just reports how students feel during their experience in the program, and it does not represent their performance in the program. So that could be something that we can expand upon in future research in this field. So in conclusion, the goal for our research here was to create a personality profile that we can use to compare with personality profiles in the literature for paramedics and paramedic students. Our main conclusion was that paramedic students scored high on agreeableness, conscientiousness, and intellect. And this matches with evidence from the literature only in that conscientiousness scores high with paramedics. Data on emotional stability and extroversion did not differ much from the general population. And so we cannot say that paramedic students score high on those personality traits. For future research, one of the main limitations for our study was the sample size. We had 16 students participate in our study, and it is noted that you need approximately 400 participants to get any conclusive evidence in the field of psychology. So for future research, having more participants would be much better. Another improvement on the study would be the self-perceived career choice satisfaction. This field could be expanded on by considering performance in the program, or the likelihood of getting a job in paramedicine, or performance as a paramedic, or the likelihood rate of burnout while on the job in paramedicine. And then that data could be used to find other patterns with different personality traits that the paramedics would take. Thank you for listening, and if you have any questions, please write them down for us.
That's great. Thanks for sharing your work there, guys. Some interesting stuff came out there, and again, I know you acknowledge the limitation of the small sample size, and the reality is here is I guess like an incubator for ideas, and it's a chance for you to have kind of played around in the space and see if there's something interesting there worth pursuing. And I think you found something that probably brought up more questions than it answered, but it gives you that first step into the field. So it's certainly not, I don't think anyone's listening to your work saying, well, it's of no use because the sample size is too small. There are questions that come out of it, and you've laid the path, I think, towards, future studies. So well done on it. It's a different topic. We haven't had groups look at things like personality traits before, but more and more we're realizing that perhaps, you need to look at who you hire into paramedic programs and into paramedic services from a personality perspective, from a non-technical skills perspective, and all of those things are, I think, very important questions to answer workforce issues going forward. So well done. I thought it was a very interesting study. You do have a question on YouTube, which is from Jen. She asks, did you happen to get a program or field breakdown for the other students? And she's wondering if there's a correlation with personality traits to those in a healthcare field versus those in other academic areas.
We did have part of our literature review was one study that looked at nursing. And the results from that study showed that nurses tend to score high on conscientiousness and emotional stability, which also matches other studies that examined paramedics for the most part. So So that was one pattern to note. And they also mentioned that those traits, conscientiousness and emotional stability, sorry about that, are associated with a high level of resilience and ability to cope with stress. So it seems like those traits are associated with higher success rates in emergency fields like nursing and paramedicine.
And was there anything from outside of healthcare that you noticed, or was that not in scope for your lit review?
We didn't examine anything outside of healthcare. The only population that we looked at that were not healthcare related were the university students from various universities in the United States, universities and colleges to say. And that was just so that we can establish a baseline personality profile to compare our results with, so we know who scored high and who scored low.
Perfect. Any questions from within the Zoom call? Just wait and see if any more pop up on YouTube. If not, then we will take a break again. So we're into our afternoon break. So thanks for sharing, guys. It was, like I said, great work, and thanks for sharing it with us. So we're into our afternoon break. We have a 15-minute break now until noon, until the hour. Prasanti has been supplied with the 2 questions she didn't get to answer. So if she has time during this 15 minutes, Prasanti, you're welcome to answer those questions. And if there are other questions that the audience, anyone on YouTube thinks of, you're free to type them in the box and I can pass them on to the students outside of this. So 15 minutes and we'll be back with our last set of student presentations and then into our closing invited talk. See you then. Okay, welcome back everyone. And we're into our last set of student presentations before we hear from our closing invited speaker. And so we're going to start off with Matthew Cassidy and his group, who are going to speak to us about their study into human trafficking, recognizing the signs education for paramedics. So Matthew, over to you and your group.
Thank you. Just getting the slides up now. Okay. Well, thank you everyone for coming out. As Alan said, our presentation is on human trafficking, recognizing the signs, education for paramedics. The presentation was done by Reshma Mandra, Connor Cosmo, Garrett Wells, myself, Matthew Cassidy, Travis Mount Stephen, and David Gutierrez. So, why talk about human trafficking? We believe that paramedics are in a unique position to possibly identify human trafficking in the pre-hospital environment. Previous literature has focused on screening tools in the emergency department. There is a limited published information on pre-hospital detection of human trafficking victims. We believe this is a gap in the research that should be investigated. As such, we are interested in assessing paramedics' confidence in recognizing human trafficking victims after receiving training on recognizing signs of human trafficking. It is known that in our local area of Fanshawe College, which is London, Ontario, and other areas along the 401, which is a highway, are hotspots for human trafficking, and paramedics may be in a unique position, given our jobs, to early identify victims of human trafficking. I saw that Alan made a post earlier about the number of different countries that are viewing this today, so let's make a quick note that the 401 highway is a highway which runs in Ontario from major metropolitan areas like Toronto, through our city of London, Ontario, and down towards the United States. The object of our study is to assess the level of confidence that first responders have in identifying signs of human trafficking in the pre-hospital environment. A quick note on ethics. Our study was approved by the Fanshawe College Research Ethics Board. To protect anonymity, we did not collect any names or specific ages of paramedics. We did have questions to identify age groups of paramedics, but we did so in a way as to break up the age groups large enough to not identify anyone specifically by their age. We do recognize that paramedics have a high burnout rate. There's not many younger paramedics. To account for this, we put the maximum age group as 40 years or older. A letter of informed consent was sent out along with our survey. Participants participate in our survey by choice, only answering questions they are willing to answer. And our open-ended questions are also optional. No participant was pressured into talk about anything that they're not comfortable talking about. I will now hand over to Travis Mount Stephen to talk a little bit about the literature review going into our project.
Thank you, Matt. And so looking at some of the literature that's out there already, we found a little amount of studies addressing human trafficking. London and Toronto, Ontario are hotspots for human trafficking, just like Matthew said. Some studies have discussed on how to identify trafficked victims. We found almost no studies at all regarding paramedics in human trafficking. We found some studies addressing doctors and nurses in the ER, but we believe paramedics are in a unique situation as we get to see the setting of where the victims are coming from, and we get a lot more information than the ER gets from the people. And Garrett has more on the literature review.
Thanks, Travis. As stated by Travis, there is a limited number of studies out there on our particular study. Based on what we were able to find, it is evident that there is research in this field of healthcare as a whole. However, the majority of that research is focused on the emergency departments and not first response, particularly paramedics. One study showed that about 88% of victims of human trafficking had contact with at least one healthcare professional at some point during the period in which they were being trafficked. The article stated that the staff assigned to this area of healthcare have received retraining to better assist these victims. There is evidence that increased training and identification workshops / courses or implementing a trafficking screening protocol have been efficient in emergency departments. One particular study included 143 women with a median age of 27 years. Overall, 46 patients screened positive for possible trafficking. 30 of those on the screening survey alone, about 65%, 7 on the physician's concern only at about 15%, and 9 at about 20% on both physician and screening survey. 10 patients were confirmed victims of trafficking. None were identified based on physician concern only. At the time of the study, the majority of victims had prior ED visits within prior 2 years. And based on those results, it's clear that a screening tool has a better success rate of identifying trafficked victims than one's judgment, or in this case, a physician. These could easily be implemented into the first response and paramedic field of work. I'm going to pass it along to Connor to talk about our methodology.
Thank you, Garrett. So just a brief discussion on the methodology that we used for our research project. The location of focus that we chose was Oxford County, which is just for people not familiar with the area, it's a small rural region just outside of London, Ontario, with a population of approximately 110,000. And we focused on working paramedics that are part of the paramedic service out there, so Oxford County Paramedic Service. So that was our location of focus for the research and surveys that we sent out. The participants were all working paramedics in Oxford County, and we specifically chose or wanted to have paramedics that they had just had a human trafficking workshop that they had recently done that was offered by their service. So we had a total of 24 working paramedics respond. And as Matthew stated, it was done via Google Docs, which is fully anonymous. And we were able to keep them anonymous and collect the data from that. Although later on, we will mention 4 of the responses were omitted due to them, those participants not completing the human trafficking session that had been offered by the service. So we lowered that to 20. So a little bit of limitations, as many of our previous presenters today have mentioned, is we just did also have a smaller general base that we gathered the data from. We didn't have as many participants as we would have liked, and then potentially in the future expand that to other services in other cities. And yet, once again, to reiterate, all of the responses were tracked via a Google Docs questionnaire that was sent out to the paramedic service. And now on to Travis.
So I'm just going to go over some of the questions that was in our questionnaire. So we started out asking for the age bracket, 20 to 29, 30 to 39, and 40 plus. Then we went into how long ago was the last human trafficking workshop or seminar that they participated in, if it was within 5 years, over 5 years, or if they have not taken the workshop at all. How do you think it is? How do you think is at risk? Sorry. Who do you think is at risk of becoming a victim of human trafficking? And that was a short answer response. Do you feel as if you know what to do when you believe someone is being human trafficked? And they would respond yes, somewhat, or no. Do you feel adequately prepared to identify human trafficking? Yes, no, or somewhat. How helpful do you believe the training you received to identify victims of human trafficking was? And that was on a scale of 1 to 10. Should paramedics receive more training in relation to victims of human trafficking? Yes, no, or somewhat. Do you think paramedics benefit from this training for early intervention in these situations over other first responders? Yes, no, somewhat. And what locations would be hotspots for human trafficking? And that was a short answer. And it'll be going to Ray for the rest of the questions.
So for number 10, were you aware of London having a high human trafficking rate? And that was a yes, no, or somewhat. 11, how comfortable, confident do you feel in making a human trafficking report? So that was another scale 1 to 10 question. Do you feel like you have adequate training available to you regarding human trafficking? Yes, no, or somewhat. How confident do you feel being able to identify someone who's being trafficked? Scale question 1 to 10. And do you know what resources would be best to report to when dealing with a patient who is a victim of human trafficking? And that was yes, no, or somewhat. And on to Garrett now.
As far as our participants went, those who met the requirements were selected to take part in our survey. Participants were selected based on whether they are active or working paramedics. We understood that not all of our participants would have previous knowledge or education in our area of research, but the overall majority should have had participated in some form of human trafficking education at some point in their career. All paramedics that were chosen came from the same paramedic service, Oxford County Paramedic Service, and they were purposely picked because of the high rates of trafficking that takes place in the region, as well as there was a human trafficking workshop that was offered to all paramedics at that service at one time. Overall, we took into account that, as stated above, not all of our participants would have had taken this workshop or would have had training at some point. Therefore, they were not factored into our data. And as far as instrumentation goes, the results we gathered were done so through a self-report questionnaire. First 2 questions of our questionnaire were just tailored to assessing the age range of our participants and the last time they had received training on human trafficking. The rest of our questions assessed the participants' knowledge regarding human trafficking and their ability to identify victims. When looking at one's ability to identify victims, there are many variables to take into account. In this research study, participants are subject to 12 questions that incorporated short answer and opinion-based. While our instrument incorporated both qualitative and quantitative answers, the instrument was done so to help us gather qualitative results. This was to help better aid us to see if there was a correlation between training and the understanding paramedics have regarding vulnerable populations, hotspots, reporting victims, and the overall effectiveness of one's training.
Okay, so when looking at the outcome measures, we are predicting that the paramedics who have participated in the study had some fundamental knowledge of whom a human trafficking victim is, that where in what areas that it's common, and that it is common in London. And we were interested in seeing if the medics are open in actually getting more training. And these areas of training can include, like, for early intervention, and to what resources a human trafficking report can be sent to. And on to Travis now.
So for the procedures of how we gathered our data, this data was analyzed in a variety of ways, such as yes or no questions. Open responses are on a scale of 1 to 10. Responses were broken down into how many people selected yes, somewhat, or no, giving a percentage of how many respondents selected which answer. And the 1 to 10 scale responses were broken down into mean and median, the mean or average providing us with a general consensus for that question.
So for the data analysis, as Connor mentioned, we had 24 participants. We did have to remove 4 as they have not taken the human trafficking training session. So we only focused on the 20 respondents because it pertains to our question if the current training in place is beneficial for early intervention of human trafficking. So I'm going to look at some questions specifically. So question number 4, do you feel as if you know what to do when you believe someone is being human trafficked? 20% answered yes, 65% answered somewhat, and 15% said no. Question number 5, do you feel adequately prepared to identify a human trafficking victim? 25% said yes, 35% said somewhat, and 40% said no and need more training. And then question number 7, should paramedics receive more training in relation for victims of human trafficking? 70% said yes, and 30% said somewhat. Question number 8, do you think paramedics benefit from this training for early intervention in these situations over other first responders? 65% said yes, and 35% said somewhat. Question 12, do you feel like you have adequate training available to you regarding human trafficking? 45% said no, 50% said somewhat, and 5% said yes. So through this study, we're able to tabulate that participating medics were still interested in having further training on this topic, and the current training in place is not enough to be able to identify a victim of human trafficking. And on to Matt now.
Thank you, Ray. Just a little bit more about the pertinent results from our survey. We're going to look at question 13 here on this table, which asks, how confident do you feel in being able to identify someone who is being human trafficked? Confidence is being left up to the discretion of the respondent as to what the definition is. Again, this was a question on a scale of 1 to 10, 10 being the most confident. Now, this question directly relates to our purpose of the study, seeing how confident the paramedics are in identifying someone who's being human trafficked. It was interesting to see the results of, as our group of 20, the average response turned out to be around 5.8, with a median of response of 6 on the 1 to 10 scale, meaning that the majority felt we realized somewhat confident out of that 1 to 10 scale, being the majority above 5. So that was very interesting to see. We are now going to move on to Connor to talk a little about the discussion and conclusions of our study.
Yeah, thank you, Matt. So obviously before and after, and finally, once we could analyze the data that we received from our questionnaires, we had a lot to discuss about the subject and about our research project as a whole. So some of the major points of discussion that were brought up amongst our group were the following. Would results differ in other services, cities, or countries? So if we had the same survey that we could send out to perhaps like a larger metropolitan based service like in Toronto, still within Canada, if the results would be different, or other countries where the first responder and paramedic structure is very different, like such as the US or the UK. We also thought whether human trafficking would be more of a factor in paramedicine, why or why not. Should the article in our review compare to our findings as well? So as Garrett and Matt previously stated, most of the literature that is out there right now is based on nurses and doctors, mostly in an emergency department setting, and paramedics being in this unique position as sometimes the first contact of help, first contact of healthcare, and being able to see the victims out in the field. It puts us in a unique and important position when it comes to human trafficking. A couple other discussion points that were brought up. Will this data influence paramedic training? Was the training received by the target paramedic service effective? As Matt said earlier, out of the 20 respondents, is around like 5.8 and 6 on a scale of 1 to 10. So it's saying that there's still kind of a gray area and there's room for improvement. But most of them responded saying that it would be beneficial. In their opinion, it would be beneficial to have more training around human trafficking. And will this training allow paramedics to provide efficient care and treatment to those victims of human trafficking in the future? Now in our conclusion, so based on our 20 valid responses via our questionnaire, as some of the questions were open-ended, the majority of medics indicated that young girls and females from low income and income backgrounds and households were potentially at higher risk for human trafficking. And also, as stated before, the proximity to the 401 highway being a major artery between the GTA, the Toronto area, down to the Windsor and the US border is also a big factor in this. And London, Ontario being pretty much right in the middle is also a big factor. So we believe that more frequent and effective training and education about human trafficking would lead to more positive results and more confident paramedics when dealing with these situations and when meeting and treating the victims of human trafficking. So we believe that this both benefited the research community, first responders, although predominantly EMS, and as well as the public. So once again, the implications of our research for researching paramedics are able to confidently recognize the signs of human trafficking, as once again, they're in that unique position of potential early identification and often the first point of contact. So there is a gap that needs to be examined due to the limited published information detecting victims of human trafficking and bringing awareness to the problem, and also bringing more to the paramedic side as opposed to nurses and doctors later on in the emergency department. So it is imperative that paramedics go through training and workshops in order to develop a broader understanding on these issues. And now on to Matt, just to finish off.
Yeah, I would just like to say thank you to everyone who came out to listen. Special thank you to Alan, Bat, and Jen for being our teachers in this, guiding us through the process. And also a thank you to the Oxford County paramedics who took part in our survey. And that concludes our research presentation. Thank you, everyone.
Thanks for sharing that with us. So you're the second group over the past few years to look at human trafficking, and I think the acknowledgement that is it is a really important role that paramedics can play and is underexplored. So kudos to you for actually looking into that. It was good to see Jen Lynn and Scott provided you with some support as well. So we have Fanshawe grads out in the field supporting research being done by students, and that's kind of the I guess the ideal world scenario that we were trying to create, was some capacity in the system where we have paramedics on the road who have the education and some experience in doing research, and then they're able to help others do it as well. So it was really good to see their names up there. So an extended thanks to them as well. If they're watching, and if they're not, then maybe if you're talking to them, just let them know that that's pretty cool. That's one of the things that we had hoped to kind of see happen. So yeah, I think the same as the group a few years ago who looked at this, it's super important. I think you did a great job of it, very well investigated and well presented. There are no questions so far on YouTube for you. Is there any questions within the Zoom call here for this group? There's a slight delay on the YouTube stream, so they're only getting to the end of the presentation now. But we have about a minute for a question if anybody does bring one up. I will say that for the NOCP revision, which is called the NOSP, which is ongoing at the moment, one of the pieces we are looking at is paramedics' role with vulnerable and marginalized populations, including those who are being trafficked. And there is some work has come out from the UK on modern slavery, which is a form of human trafficking. And so paramedics are starting to look at this, and I think that's, a really good thing. Oxford County Paramedic Service have actually joined us on YouTube and have asked, what would you suggest as first steps for a service looking to raise awareness and conduct training in human trafficking? So first steps for a paramedic service.
Well, I think that first steps, of course, would be having a established definition of who a human trafficking victim is given to the paramedics, because identification, the first step is having an understanding of the problem. And as we discussed before, screening tools might be good. And of course, having them equipped with resources that they can use to give to potential human trafficking victims that they find. I think those are all very good steps that we could implement in the future.
Yeah, and I think we could acknowledge that Oxford County are doing this, and have paramedics undertaking human trafficking education. So I think to kind of provide my perspective on this back to Oxford County Service, I think doing what you're doing right now is a fantastic first step, and I think there's a lot of services can learn from this. It shouldn't just be the services on the 401 corridor. Human trafficking happens everywhere. And so, the fact that you're providing some leadership in this area, I think is really important to acknowledge. So in the interest of the other groups having their time, I will not ask any further questions, but you do have 2 more questions that I'll provide to you in the Zoom chat, and we can maybe get some answers to throw on YouTube for those. But thanks again for sharing your work, and good job. Next up, we have Jamie Korganowski and her group, who are going to speak about about violence towards paramedics. And I know that Justin is watching on YouTube, so Justin will be interested, I'm sure, to ask you some questions and hear your thoughts. So over to your group, Jamie.
Sorry, just 1 sec. The drop down keeps getting in the way, so I can't click on it. So 1 second here. What is happening? All right. Can everyone hear me fine? Hello? Yeah, okay, perfect.
Yeah, you're good.
Sorry, my computer is very touchy right now. All right, sorry about that delay there. My apologies on that one. So again, thank you for coming to our presentation. So today we will be presenting our research, which is investigating the prevalence of violence towards paramedics and potential resolutions. So today you'll be hearing from Jenna Gibbon, Jamie Korganowski, myself, Rebecca, Aaron Lyons, and Claire Skubik.
So this is the agenda of our presentation today. We're going to start off by talking about why our research is important, the background, our literature review, our hypothesis, our methods, limitations, results, and finally conclusion. Next, we have Rebecca outlining why our research is important.
Okay, so my name's Erin. I think there's just a little mix up, but I'm just gonna kind of outline why we feel our research is important. So we focused on investigating the prevalence of violence towards paramedics and wanted to analyze like the type, the frequency, and like all of that of why, what they experience at work. This is important because it can help us to see if changes can be made in order to make a safer working environment for paramedics.
I think most people on here can like appreciate that paramedics' work environment is not very controlled, but having training in place to facilitate like safety for paramedics should be a priority. We were curious to see if the results would reflect the working paramedics feeling that implementing self-defense or de-escalation training would be a beneficial addition into Ontario colleges for their paramedic programs. And Claire's just going to give you a little bit of background on our study.
So this is the background of our research presentation. And while an ambulance is considered a paramedic's office and dealing with the general public, paramedics face many different types of violence on a day-to-day basis. Paramedics often find themselves in vulnerable situations when alone in the back of an ambulance, especially with a combative patient. Types of violence our research today is looking at is verbal and physical assault, intimidation, sexual harassment, and sexual assault. We're also investigating how different populations feel about the prevalence of violence in their paramedic career. Male and female paramedics may have differences on this experience simply due to gender differences. New paramedics may also sometimes feel more vulnerable to violence than older, more experienced paramedics. We will also look at the experiences of paramedics working for urban and rural services and how rural services may feel more vulnerable due to lack of resources. The picture in this slide may be very familiar to many of the medics online today. It has been posted in ambulances across Ontario stating that there is zero tolerance for any sort of abuse against paramedics. This is unfortunately outlining that it is a prevalent issue. Next, Rebecca will be talking about our literature review.
Sorry. So as Claire stated in the previous slide, violence can come in many forms and can affect anyone. From the literature we reviewed, we can reference Bigham et al., where it was found that of the forms of violence, verbal assault was the most common, sitting about 67%, followed by intimidation at 41%, physical assault at 26%, sexual harassment at 14%, and sexual assault at 3%. It was found that 78% of medics reported a violent act while in their prior year. From that same article, also 97.9% of medics in the Peel region experienced violence when studied by Moz. Like Claire stated, there has been research done on if males or females experience more violence than the other, and it was found in McGuire's article that men and younger EMS workers tend to experience more assault than their counterparts. Another study conducted by Klenko et al., they found that paramedics had to seek their own self-defense training, and that only 9% were ever offered anything by their employer.
So I'm Jenna. I'll just be going over our hypothesis. So we predicted that the majority of participants would have had at least one experience involving a violent act while working as a paramedic, with an increase in frequency in areas of greater populations. We think this would lead to an increased need in violence de-escalation or self-defense training to be added into the Ontario Paramedic College programs. For the purpose of our study, we also included a few definitions into our survey. De-escalation training referred to the teaching of using calm verbal communication to create a safe space and diffuse a potentially dangerous situation. Self-defense training referred to the teaching of assertiveness, awareness, communication, and physical techniques to protect the safety of an individual. So next, Jamie will be discussing our methods.
Hi everyone, I'm Jamie. I just want to apologize in advance. I'm not really sure if my camera is working and I'm not sure why it's not coming on. But anyways, I will be discussing our methods. So our questionnaire was sent out to paramedics across Ontario via social media, such as Facebook, Instagram, email. We requested each region to share our survey to their service. Our questionnaire consisted of 30 statements and questions, and it was asked to be completed anonymously on Google Forms. Some of the questions consist of history with violence while at work, personal views on safety, and some demographic information such as age, sex, current place of work, and how long they've been a medic. Overall, we got 99 responses from 16 different services. And next, Erin will be talking about some limitations.
Erin, your mic's muted.
Thank you. So I'm just going to go over some of the limitations we found. So one limitation we found was a difficulty reaching our targeted participants. We reached out to 50 different services across Ontario and received responses from 16, as Jamie mentioned previously. So due to this, we acquired a limited audience, and with that, limited responses. Similarly, we found that because we couldn't reach all those services, we received a higher number of responses from specific counties, which that had the ability to skew our data just based on like having so many from one service and none from another. And relating to that, we had 8 responses that didn't specify which county they were working out of. So there was a bit of a wording issue on our survey, and those would have the impact to skew our urban versus rural data. Another limitation was a bias within our questions. So some of the wording within the survey could lead participants to answer a prompt in a way that strengthened our hypothesis rather than how they would have answered with less definitive options or a more open-ended question. And we had questions pertaining to participants' demographic information, but we didn't include any questions regarding race, ethnicity, or culture. And by not including this, we created a limitation as we can't analyze how these factors could play a role in the violence that paramedics experience. And next, Rebecca will break down our results.
All right, perfect. So the next couple of slides will break down the types of violence experienced, and then we'll progress into more of a breakdown analysis of the results to determine if the prevalence of violence in paramedicine and if medics believe there's intervention needed. So to break down the types of violence, so you can see from the slide here, we'll be looking at verbal, physical, sexual, psychological, and cultural. We did this so we could kind of compare back to that literature review. All right, so starting from the highest instance to the least, verbal violence occurs in 100% of medics we found, with only 6% saying it is rare. This result goes hand in hand with the findings of that literature review, like I stated, with verbal violence being the most common form. The next highest rate was the physical violence. So about 84.8% of medics experienced it. Thankfully, only 1% say they ever experienced it with a weapon. So the third in line is psychological violence. So 79.8% of participants said they have experienced it, with 55.6% saying it is not a rare occurrence. Second last is cultural violence, which is included but not limited to race, culture, religion, or tradition, with 51.5% reporting that they have experienced this type of violence. While our research we studied did not capture any aspects of cultural violence, we can kind of go back on their findings of intimidation, or in this case, the psychological violence, being one more of the higher rates that have been found in other research. And lastly, we have 46.7% of medics say that they've experienced sexual violence, while just under half of those stated that it happens sometimes to often. We have Claire.
So the results on this slide is more related to safety when it comes to police and or allied resources. The graph below shows that over 90% of medics have experienced violence while police and allied resources were present. And in another graph on our questionnaire, it showed that 21% of medics have reported that they do not trust their allied resources to keep them safe in dangerous situations. So the results on this slide is aimed towards violence with colleagues on calls and the degree in which medics feel safe while on call. So over 90% of medics have reported that they witnessed violence occur towards their colleagues while on call, as shown in the graph below. And almost 89% of medics claim to feel safe while they're on call.
So the frequency, we found that almost 84% of participants have experienced violence on shift within the last year. So that works out to be it works out to be 83 of the 99 people that we surveyed. And the visual on the side is just so you can see kind of like how it works out. The light blue shows you how many medics have experienced violence within the last year, and the dark blue is those who haven't. And then we found that just over 38% of participants have experienced violence more than 10 times within the last year. We also looked at missing time due to violence experienced on a call, and we found that just over 16% of participants have been kept out of work due to violence. And although this may seem like a pretty small percentage, it works out to be about 1 in 6. So that puts it into perspective a little bit more, that it affects more people than you'd expect.
So these are some interesting findings in regards to self-defense and de-escalation training. So an interesting finding was when the participants were asked if they have been offered self-defense training through their employed service, we found 80% of people have not. We also found that 77% of participants have also not been offered de-escalation training for given situations. With this information, we found that almost 20% of participants were prompted to take either self-defense or de-escalation training on their own time since becoming a paramedic due to past encounters. We found the information from the previous slide very interesting, as our following post statement in our survey was, I feel that implementing de-escalation training into paramedic training in Ontario colleges would benefit the safety of paramedics. We had a response of 95% of participants who agreed with this statement.
So next, I'm just going to be comparing some of the demographics that we looked at. So first, urban versus rural services. For reference, we defined an urban service as having a population greater than 120,000 and rural as less than 120,000. When analyzing frequency reported, there was a significantly less percentage of paramedics who have experienced more than 10 counts of violence in the past year in rural services, when compared to paramedics who work in urban city services, as you can see in the top right corner. In conducting our analysis, we also wanted to see if there was a difference in types of violence experienced in urban versus rural counties. Generally, what we found was that there wasn't, and trends were very similar across all services that we had received responses from. Regardless of location, verbal and psychological violence were reported to us as having been experienced more frequently, with weaponized and sexual assaults as being less frequent. Next, we wanted to compare responses from males and females. Our research showed that males and females are almost equally likely to experience violence. And again, as shown in the right corner, there were similar trends with police and allied resource present. The biggest difference was with the outliers. We only received responses from females who had said that they had never had an experience of a violent act while police or allied resources were present. This means that every male who responded to our survey had had an experience of violence with an allied resource present. Based off our data, it could be predicted that males are more at risk to experience violence with allied resources present. However, more research regarding this should be done. When looking at gender differences regarding types, there was no significant differences between sexual, verbal, and physical violence. Similarly, violence involving a weapon and cultural violence had majority of responses reporting as never or rare occurrences, regardless of gender. For psychological violence, there was a greater frequency reported by males. 70% of males reported this as a sometimes, often, or always occurrence, compared to 41% of females who reported this as a sometimes, often, or always occurrence. More research, again, should be done to look at the effects of violence on the psyche, and this could include the types of calls that affect males versus females, or if there are differences in the way that males and females are treated that could play a part in their reaction to a situation. Finally, following the completion of our research, our final question was regarding whether paramedics felt that there was an additional need for safety protocols to be implemented into college training. 76% of participants in our survey agreed that there is this additional need, with similar trends in both males and females. However, slightly more males agreed at 83% compared to 68% of females. So in conclusion, paramedics experience various types of violence regardless of gender, age, experience, or where they work. We recommend that by implementing additional training into Ontario College paramedic programs, we can help to create a safer work environment in which paramedics feel better prepared for these worst case scenarios. I'm sure everyone here can agree that at the end of the day, returning home is always going to be our goal.
This is the end of our presentation. Thank you for listening. If you have any questions, feel free to put them in the comments, or you can always email us at violencetowardsmedics@gmail.com.
Good job. I was there 5 minutes, 2 minutes, 1 minute, and then you were on your conclusion. So it was a great presentation. Thanks for sharing it with us. So Justin, who you cited one of his papers earlier from Peel Region, is on this call as well. He's watching it on YouTube. And so since your group entered into this project, there is a large scale Ontario wide project looking at violence against paramedics. And so I think, you know, if any of you are interested in continuing this work, there's definitely space for you to help us on the Protect Paramedics project. But it just goes to show that, and I was messaging Justin as we were, as you were talking, and it was, you know, the acknowledgement that the fact that you're actually looking at this is really important. The fact that students are, you know, the new generation are looking at their job and saying, well, hang on a second, like, why should we have to put up with this? And how can we do this better? And so I think that that's really important to acknowledge that, you know, as a group, you were the first group in Fanshawe to look at violence against paramedics. There are 2 groups in the current first year class who are looking at violence against paramedics. One group which is working on the Protect Paramedics one. I just think acknowledging that is really important. So Justin has come on to the chat here and he said, really great presentation, important issue. Curious to hear your thoughts, if you're comfortable, as you enter the profession, about violence as one of the risks you may face in the work.
I mean, this crossed my mind, obviously. Like I think I'm a little biased being a female, that there's always like this aspect in the back of my mind that I am nervous, and I'm nervous to be in the back of an enclosed vehicle with somebody that could potentially hurt me. And actually, me and my other medics were talking the other day about, you know, okay, you know, firefighters can hose you down or something like that if someone's coming at them. Police have like batons and tasers, and what do I have? Shears? Like there's nothing protecting me at all. And because we're in such a small, you know, back spot, it's something that, yes, I've been concerned with, but it's never been something that has held me back from pursuing it. So I don't think it's stopping me, but it's definitely something that, yes, needs to be addressed so that everyone can stay working in this profession longer, because, you know, there's obviously other things that stop us from working, you know, years and years. What this one shouldn't be one, essentially.
Yeah, I'd agree with you on that. So in the interest of time, I'm going to move on to the last student group. I have an extra question from YouTube that I'll swing into the Zoom chat for you and you can answer it. But great job. Thanks for sharing your work. And so over to the last student group before we hear from our closing invited speaker. So we're going to hand over to Sarah Azalas's group. We're going to speak about paramedic students' attitudes towards persons with substance use disorder. So Sarah, over to you. If someone is talking, you're muted, just FYI.
Can you hear me?
Yeah.
Thank you. Good afternoon. My name is Carissa. Today, along with Sarah and Megan, we will
be presenting student empathy levels towards substance users. Next slide. Thank you. Today's agenda for our presentation, Sarah will be starting us off with an introduction, followed by our background, the purpose of our research, our method and results, discussion and limitations, and Megan will conclude with closing remarks.
Sorry, Sarah, there's no audio coming from you. No, nothing still.
How about now?
Yes. Yeah.
Okay. Okay, so as Krista mentioned, my name is Sarah, and to start off this presentation, I want to invite you to close your eyes and imagine that you're at base and it's 3 a.m. You're all warm and cozy, finally getting some sleep on a cold winter night after the start of a busy start to your night shift. Suddenly, you're woken by the tones. You're responding code 4 to an alleyway for an unwitnessed overdose. As you jump into the truck, dispatch gives you the details, and you realize that this is an individual that you've responded to many times. As you leave the station and you feel the cold, crisp winter air on your face, how are you feeling? You can open your eyes now. If you found yourself feeling frustrated, angry, or lacking empathy towards the substance user population, research suggests that you're not alone. Megan will expand more on this in the following slide.
So just a little bit of background information regarding this topic. Research regarding empathy in paramedics is relatively new, with most of the available research conducted within the last decade. We reviewed 6 different studies regarding empathy levels of both paramedic students and practicing paramedics. In the majority of the available literature, paramedics are shown to lack adequate empathy when interacting with their patients. In particular, the literature indicates that paramedics display the least amount of empathy towards patients living with a substance abuse disorder. This can be viewed as problematic due to the fact that it could hinder the quality of patient care, ultimately worsening clinical outcomes. The reviewed literature also highlighted the need for evidence-based studies involving practicing paramedics, as well as professional development and education regarding alcohol and substance abuse. And as for the purpose of our research, ultimately the purpose is to investigate and find out paramedic students' empathy levels towards those living with a substance abuse disorder. And now Carissa is going to go through our methods.
Our study was a cross-sectional research design targeting first and second year primary care paramedic students only at Fanshawe College. Our participants were recruited by emailing the entire first and second year class. The study was conducted using a medical condition regard scale to investigate why paramedic students lack empathy towards a certain population. This questionnaire included 11 statements allowing participants to respond using a Likert scale. This MCRS has been utilized in a 6-point Likert scale, from 1 being strongly agree to 6 being strongly disagree. The lowest possible empathy score is 11, and the highest possible empathy score was 66, which Sarah will further explain later on. This method we found to best show the comparison between first and second year paramedic students' level of empathy after working and interacting with this population.
So we had 32 out of a possible 90 students participate within our survey. This is about a 30% or 36% response rate. 22 of the participants were first-year students, making up about 68% of our participants. The remaining 10 participants were enrolled in second year. So when analyzing the responses to the MCRS statements, we found that first years had a mean empathy score towards the substance using population that was 44.4 out of a possible 66 that Carissa mentioned earlier. The standard deviation was 8.3.
The second years demonstrated a mean empathy score of 40.5 with a standard deviation of 10.2. The graph, the left graph on the bottom there, are the positively written statements within the MCRS. The one on the right are the negatively written statements within the MCRS that had to be reverse scored before we were able to establish the empathy score. Interesting to note is that second years had a higher empathy score on the statement regarding insurance plans should cover patients like this to the same degree that they cover patients with any other condition. This was the only statement that second years scored higher on. These same second years scored significantly lower when responding to this statement. I enjoy giving extra time to these patients. The results of our studies suggest that first years have more empathy to those with substance use disorder than their second year counterparts.
The outcomes for the study showed that the second year students have lower empathy for substance use disorder patients than first year students. We found that students may exhibit negative feelings towards this population due to the fact that many healthcare work as self-inflicted with lots of negative stigma surrounding it. Our results showed that first year students have a higher regard for substance users. Perhaps this higher regard may potentially be explained by less exposure to this population. Overall, reconstructing the substance use disorder curriculum into the program would greatly benefit students and how they provide care to this population going onward.
There are a few limitations to our study that I just want to address. The first one is that we used a convenience sample, and because of this, it facilitated simpler recruitment. However, the results from our sample may not be representative of paramedic students across Ontario or Canada. A large margin of error must also be considered due to our smaller sample size. We did not have any controls set in place so that participants could not answer the survey more than once. So they may have answered it more than once. We just have no way of telling. There's a lack of information on those who chose not to participate in our study. And lastly, because the MCRS questionnaire is a self-reported survey, there's always a possibility for self-report bias.
Okay, so to conclude our presentation, I'm just going to reiterate some of the key points. So research regarding empathy in paramedics is relatively new. The majority of available literature exposes that paramedics are shown to lack adequate empathy when interacting with patients living with a substance abuse order. The results from our particular research suggest that first year paramedic students have a higher levels of empathy towards those living with a substance abuse disorder in comparison to fellow second year paramedic students. The current literature, along with our research, highlights the need for evidence-based studies involving practicing paramedics, as well as professional development and education regarding alcohol and substance abuse. In addition, our research also brings to light the possible need for more education surrounding empathy within the paramedic curriculum. Moving forward, future studies and research may benefit from collecting more participant demographic information such as age, gender, previous education, and previous experiences, which could provide more insight into this topic. Carissa, Sarah, and I would like to thank everyone for listening to our presentation. And if there are any questions, we will do our best to answer them.
Thanks very much. That was good. Thanks for sharing your work with us. I think it's not surprising that you found the same empathy issues that seem to just be pervasive in paramedicine. And I think the trend in the literature was generally that early career, like first year students are generally more empathetic. We still don't know why that is, likely lack of exposure. But it could also be, and we were just, messaging a few people back and forth on different platforms about the presentations today, that maybe these things are going to start changing, that even if it's still lower empathy in first and second year students, in paramedicine right now, that the mean marks could actually still be higher than previous years, because there seems to be a change in student perceptions on certain issues and what's becoming a priority and what's being focused on, evident in some of the research topics that you're all actually addressing. So even though they're, it's still technically low, I'm wondering, is there going to be a pattern emerge that it's getting better, and that we're starting to acknowledge these things a bit more. You have a comment and a question on YouTube. So Justin says that it's such a timely topic. Opioid overdoses are being described as one of several shadow pandemics that we're dealing with because of COVID. And I think Jen will probably touch on that next as well, to say that, that there was a large focus on the opioid epidemic, and then it was forgotten as soon as there was a pandemic, and certainly the impact of that is rising in the background behind COVID. Justin asks, regarding first versus second year empathy, do you think that empathy changes from first to second year? And I guess, why might that be? And I think you've probably kind of touched on some of that. Like, I guess one way to frame it would be, do you find yourselves having less empathy towards this particular population from first year to now, because of exposure in the clinical environment, or do you have any other thoughts on it?
I think probably like in first year, when you're super eager, like starting out in this profession, you'd like to think that you're going to be empathetic towards everyone. And when you experience like these individuals in real life situations on real calls, it can kind of affect you differently. And then, yeah, I think it's like mostly the exposure and your experiences with these people.
Yeah, I think that's a fair response. Carissa, did you have something to add to that there? Or? I noticed you were unmuted, so sorry.
Yeah, I think it's just if you become like exposed to the same population over time, it might wear down on like your mental health. And if you, like Sarah said at the beginning, if you're getting called at 3 a.m. for the same person that you've had previously, like you might not be the same compassion and empathy as you were maybe when you first started off as a medic, or even just as a student as well.
Yeah, and I think, not that I set these things up to prove certain things, but the reality is a lot of the work that your group and other groups have put forward here shows that we're probably preparing you for a job that is not like what you actually end up doing, that we don't focus on teaching you some of the techniques that you will need. It's like you can teach empathy, and that's been proven, but we perhaps don't focus enough on that, and that there's a disconnect there between the curriculum piece and perhaps the needs of paramedics in clinical practice. And then the last piece would be that whole, it really is foundational to most of the studies that have been brought up here today, is this non-technical skills piece, the communication, the empathy, the understanding of others, compassion. All of these things seem to be core to what we're doing, and we're just perhaps not acknowledging that enough. You have another question here on YouTube from Jen. So how large of a role do you feel preceptors play with regards to empathy levels towards substance users? I don't know if it came out in your research as such, but just your opinions on it would be useful.
Yeah, I think just like with anything, when you're exposed to people who have differing opinions, if your opinion isn't like set in stone and like you really feel empathetic towards people, like you are going to trail off of like your own like perceptions of things. And if say your preceptor is super empathetic, then you might follow that role along with that until you start developing like your own opinion later on. And then before, on the flip side, if they are the ones that are making those comments, even though they might be small comments and side comments, like you do pick up on them, unfortunately.
Yeah, there is that whole piece around the, this hidden curriculum stuff that also needs to be better explored in paramedicine, that we write down what we want to teach you, what we actually teach you kind of differs slightly. What gets put into practice out on the road differs slightly again. And then there's all this stuff that nobody talks about, like the comments and the socialization and all of these hidden pieces that can very much influence your practice as a paramedic. So I think even for your generation of paramedic students to acknowledge these things, I think is really important. And, I think we're we're moving towards paramedic students, I think, who are able to stand their ground a bit more and perhaps view things quite differently to some of the older generation of paramedics that are in practice. And that's not a bad thing. Changes, it's not necessarily an easy thing that we're going to have to deal with as a profession, but it's not a bad thing. You know, different views and different perspectives on things, I think, are useful. So again, thanks for sharing your work. I think it's super important, and well done for looking at it. And it's a nice segue into our closing talk. So I'm really pleased to hand over the last portion of today to Jennifer Bolster. And so Jennifer is an ACP and paramedic practice leader with BC Emergency Health Services. She's a member of the McNally Project, like I said earlier today, and she's also an honours student in Monash University, and she's going to speak to us about substance use and the role of the paramedic. So over to you, Jen.
Thanks, Alan. So yes, I could not think of a better segue to my talk as the work that those ladies did. Thank you so much for that work. It was really insightful. So yes, my name is Jen Bolster. I am a BCEHS Advanced Care Paramedic and Paramedic Practice Leader. I'm also a Bachelor of Paramedicine honors student with Monash University. And today I will be presenting the work I've done so far on my literature review, Substance Use and the Paramedic Role, a scoping review. So before I begin, I'd like to acknowledge that I join you virtually today from the Squamish, Musqueam, and Tsleil-Waututh nations. So this is a picture of me in front of my BCEHS ambulance at my second home station 261. So for those of you who aren't familiar with BCEHS, Station 261 is situated in downtown Vancouver and is really well known amongst the paramedics and the greater community alike to be a hub for substance use. So it's really been a focal point of the overdose epidemic in BC in the past decade. So the majority of the time that I spent working at Station 261 was spent on Vancouver's downtown east side. The downtown east side, or DTES as it's more commonly known, is where I became intimately familiar with the overdose epidemic and the community of substance users that reside there. So these experiences humbled me, saddened me, and completely reshaped the way I view addiction, harm reduction, and my role as a paramedic. In February of this year, I left my position as a Station 261 Advanced Care Paramedic and began my new role as a paramedic practice leader for the mental health, substance use, and opioid epidemic clinical practice areas. So in my new role, I have the absolute honor of speaking with provincial leaders of harm mitigation and reduction strategies, such as the BC Centre for Disease Control, the BC Centre for Substance Use, and the Ministry of Mental Health and Addictions. I've also been tasked with innovating better ways for paramedics to care for those who use substances. And so it made perfect sense for me to focus my educational pursuits on the topic of substance use and the paramedic role. So I am hired as a BCEHS paramedic practice lead, and my clinical practice area does include substance use and the opioid epidemic. I have received no funding from my BCEHS employer to complete this work. And I'm also hired as a senior research assistant by Fanshawe College for the work on the Canadian Standards Association National Occupational Standards for Paramedics project, in which one of the contexts of practice is caring for marginalized groups, including those experiencing substance use disorder. So exactly 2 weeks ago, my paramedic colleague, Richard Armour, and I were working together on the downtown east side. And as we were driving down East Hastings Street, we saw spray painted in huge words along one of the brick walls of a low-income housing building, "Safe Supply or We Die." 10 minutes after seeing this, Richard and I found ourselves experiencing these words, attempting to resuscitate a resident of the downtown east side that had used drugs, had overdosed, and was now in cardiac arrest. So there was no way to know that the drugs that this person used were contaminated with fentanyl or benzodiazepines or other substances. But 10 meters from the sidewalk, what was abundantly clear was that this death was preventable. So what are paramedics doing to prevent substance use related death? What can we be doing? What is our role and what can our role be? The purpose of my literature review is to better understand what the role of the paramedic is in caring for those who use substances. So in my review of the literature prior to commencing the study, I found a lot of literature around overdose response. And although our response to opioid overdose is highly important, we're playing a different game now when it comes to the overdose epidemic because we are no longer just dealing with opioids. In fact, in BC, benzodiazepines were detected in 52% of drug samples in January of this year. Benzodiazepines increase the risk of overdose by depressing the central nervous system and can make reversal of opioid overdoses much more complex. Stimulants has also been found in very high samples, up to 90%. In April of 2016, a significant increase in illicit drug-related emergency events and deaths in British Columbia prompted the BC Provincial Health Order to declare a public health emergency. Since that time, deaths due to illicit drug toxicity have continued to increase in BC, with an average of 6 illicit drug toxicity deaths per day in 2021. This is more than double the number of deaths since the public health emergency was declared. So illicit drug toxicity is the leading cause of unnatural death in the province of BC, accounting for more deaths than homicides, suicides, motor vehicle incidents, drownings, and fire-related deaths combined. The primary cause of increased deaths is the growing toxicity and unpredictability of the street supply of drugs. Although a number of provincial initiatives have been undertaken in an attempt to address the drug toxicity crisis, these initiatives have not been sufficient to stop the rising death toll. So a new approach is required, one that includes a specific focus on the toxic drug supply. Coinciding with the emergence of COVID-19 restrictions, an increase in the concentration of fentanyl was detected. From April 2020 to July 2021, approximately 13% of deaths had extreme fentanyl concentrations. However, fentanyl and its analogs were detected in 85% of illicit drug toxicity deaths between August 2017 and July 2021. So in BC, approximately 50% of patients who experience an out-of-hospital overdose refuse emergency department conveyance. And in this cohort of patients that are not conveyed, they're at much, much higher risk of 12-month mortality than those who are conveyed. And a contributor of this is the access to outpatient services such as opioid agonist therapy and safer supply. So in BC, we're about to roll out an assess, see, treat, and refer pathway for patients following an overdose. This pathway, when utilized, will connect patients who refuse conveyance to outreach services, which improves upon the current model where the non-conveyance takes place, and then we don't really know what happens to these patients, including if they were able to seek out services that mitigate harm. We're also working on an organizational initiative that will allow paramedics to administer Suboxone, which is buprenorphine and naloxone. This will be administered in acute withdrawal and also in take-home form for those looking for opioid agonist therapy but are not in acute withdrawal. So my hope is that I can marry my work as the substance use practice lead with BCEHS and my honors scoping review to aid in utilizing current evidence to determine what the evidence suggests about the paramedic role in caring for those with substance use, what the gaps are that require research attention, and ideally be able to translate that back into the research community so that further study can take place that will then translate back into practice where it's desperately needed. So my research question is, what is the paramedic role in caring for those with lived and living experience of substance use? So I paid special attention to the language of my research question because I really wanted to focus on the paramedic role. So I did not choose paramedic response or paramedic management or paramedic treatment because I think that modern literature will begin to show that the way in which we care for patients is becoming much more holistic and extends far past traditional responses. So the focus of the question is not on managing an overdose because we already have the tools to do that. And those are well documented and reported in the evidence. What is less highlighted in the evidence is what we are doing as a profession to prevent substance-related deaths, reduce harm, and offer alternative options for care that exist outside of the constraints of the traditional arms, being ED conveyance and refusal of care or treat and release. So I chose substance use over opioid use because, as previously mentioned, we are no longer dealing with just opioids, and not all substance users use opioids. And I chose to focus on the broad topic of substance use over the opioid crisis because I wanted to capture everything else that we're doing to care for those with substance use, not just how we respond to them when they experience a drug toxicity event. So a scoping review is defined as a type of research synthesis that aims to map the literature on a particular topic or research area and provide an opportunity to identify key concepts, gaps in the research, and types and sources of evidence to inform practice, policymaking, and research. I chose a scoping review over a systematic review because I really wanted to cast a huge net on this very broad topic, and from there be able to extrapolate what the key concepts and their characteristics are. I could not find any existing scoping reviews on the topic of substance use and the paramedic role, which further inspired me because it was important to me that the work that I was doing would be filling a gap in the literature. Further, I wanted to identify what the types of available evidence are, clarify key concepts and definitions in the literature, examine how research is conducted on the topic, and then most importantly, identify and analyze what the gaps in the knowledge are. So I used the Joanna Briggs Institute manual for guiding the creation of my review protocol, which will adhere to the framework created by JBI for scoping reviews. I'm currently on stage 3, which is the study selection phase. So I've created a graphic seen on the right to actually represent how long each phase took me relatively. And I'll add here that this is my first scoping review. And so it is entirely possible that these phases took me longer than they should have. So in stage 1, I identified my research question, which took me a fair amount of time, but not too much because I already had a pretty good idea of what I wanted to do my review on. And from there, it was really just about making sure I worded my question right. From there, I utilized the population, concept, and context, or PCC framework, to decide how I was going to break down my research question into a search strategy. Then in stage 2, I came up with my search strategy, which actually took a long time because I really wanted to make sure I was capturing all of the relevant literature, but also ensuring it remained focused on the research question. So for example, opioid and paramedic search terms will also populate every study where paramedics administered opioids. So I needed to be very careful about what terms I decided to do full text searches on and what terms I wanted to just get title and abstract hits on. Then I ran my searches and this took the longest. I'm confident that this has more to do with my patience and less to do with my search strategy, but nonetheless, lots of searches were made and lots of lessons were learned. Big take homes being saving my search strategies and saving my searches and documenting changes made to my searches, my search strategies, and their corresponding results. So I then imported all of my searches, which didn't take much time at all once I figured out how to export them into the correct format. So I'm now in stage 3, where myself and 3 other researchers will complete abstract and full text screening before moving on to data extraction. My supervisor, Dr. Alan Batt, will resolve conflicts during screening and offer support throughout the rest of the study selection process and onto charting, summarizing, and then reporting the results. So this is a table that outlines my PCC framework. For population, I chose to do substance users. For my concept, I chose to do substance use. And for context, I chose to do the paramedic role and out-of-hospital care. I should add here that although community harm reduction teams are technically out of hospital, for inclusion, the literature needed to be pertaining to paramedic delivered out-of-hospital care. And this is my actual search strategy. I'll also add here that some of the terms I decided to use in my search strategy are not words that I like to use, nor are they trauma informed. But in an effort to scope all of the evidence, I wanted to make sure I captured even the literature with slightly out of date language. I used the gold standard for paramedicine related search terms created by Dr. Alex Olausen for my context searches. And I actually found a really great library reference for substance use search terms, which ended up being extremely helpful. And then it was just up to me to determine what truncations and other advanced search strategies would be required to yield the results. So my inclusion criteria is quite broad. It just needs to be related to paramedic care and substance use and be in English language for it to be included. Studies related to paramedic substance use or paramedics using substances will be excluded. Studies pertaining to isolated alcohol use or alcohol use disorder will be excluded, and studies pertaining to excited delirium will also be excluded. I should add here that I was alarmed by the number of studies I came across pertaining to the incidence of substance use amongst first responders, and that although the literature around paramedics using substances will be outside of the scope of this study, I'll say that it really does warrant an area of focus in and of itself. So the search databases that I used were Medline, Embase, and CINAHL. The results that I yielded from Medline, 1,530. The results I yielded from Embase was 1,943, and CINAHL, 1,765. I did decide to include gray literature to ensure that the full scope of the research question is investigated and conceptualized. The CADITH Gray Literature Checklist for Canadian Health Professional Association's website was referenced, and the main source of gray literature was used using both Google Scholar and the search engine Google, where I reviewed the first 1,000 results from a search of Google Scholar. The utilization of gray literature will be imperative for this review, and that's due to the ever-evolving culture and worsening crisis state of the overdose epidemic globally, which may necessitate modern and controversial approaches to the subject matter that may only exist outside the constraints of peer-reviewed publications. So the total number of searches imported into Covenants for screening after duplicates were removed was 3,780. There are 3 screeners, including myself, and then my supervisor and I will resolve conflicts. I will use the data to summarize and report the findings into the scoping review paper following the JBI framework for scoping reviews. For my own academic integrity, it is essential that the other reviewers are not involved in the editing and reviewing of the review protocol or the final paper until after it is marked by Monash University. Once the review is marked and returned, I can submit the paper for peer review and publication. So my next steps will be uploading my protocol to the Open Science Framework, commencing abstract and full text screening, data extraction, authoring of the paper itself, and then submission to Monash. So although I haven't reviewed all of the literature yet, some possible implications of the review findings based on my current understandings are curriculum guidance and acknowledgement of the gaps in current paramedic education. So here in BC presently, primary care paramedics complete 4 months of didactic learning, and we all know that this is simply not enough time to teach the inner workings of trauma-informed practice, the social determinants of health, and some of the other pillars of holistic and preventative out-of-hospital care. And when it comes to substance use and opioid response curriculum, some of these issues are quite deep-rooted and complex, and sometimes even bred into us. So you'll find in most paramedic textbooks that you need to beware of the patient who is woken up by Narcan because they will be likely angry and violent towards you. But what we don't focus our education on is what the physiology of acute opioid withdrawal is and how uncomfortable and painful that is. And trauma, not the MVI wound packing trauma, but actual emotional and psychological trauma. And I'm really interested to see what educational themes arise from the review. But what I predict is that one of the themes will be that paramedics, especially Canadian paramedics, are globally underprepared and educationally under-equipped to care for these patients on a whole. So I hope this work can help in guiding future policy and procedures, even if that means simply altering our approaches to these patients and to this practice area from reactive and responsive to proactive and preventative. I predict that paramedics that read this review will be inspired to pause and reflect on their practice and the patient care that they deliver. And ideally, this will spark the same innovative spirit that has been sparked in me to help with pushing their organizations to consider revolutionizing the way we deliver services. I think that the moral, ethical, and philosophical implications of this review, however, are going to be the most impactful, because I believe what we're going to see is that we need to begin reshaping what the paramedic role is in caring for substance use patients. We are these patients' first point of contact with the healthcare system, and what we offer and how we treat them is going to hugely influence their journey, for better or for worse. And remember that in BC, 50% of patients who overdose deny ED conveyance. And these patients are at much higher risk of 12-month mortality. So that's 50% of this patient population that we can be offering services to that can reduce harm. And I think that that is a privilege. And I think that the review will show that we need to respect the importance of the paramedics' connection with these patients and the services that these patients really need. So I'll just end by saying that in order to truly understand what those services are that patients need, we need to ask them. So I think another major implication of this research will be an emphasis placed on peer engagement of those with lived and living experiences of substance use. So Dr. Alan Batt always tells me that I thank him too much, but I really can't help myself. So I'd just like to take an opportunity to thank Dr. Alan Batt for his support as a supervisor and mentor and for inviting me to speak today. And I'd also like to thank Richard Armour and Michelle O'Toole, who have graciously agreed to contribute to this scoping review. So because this is my first scoping review, I'm really dedicated to collecting any and all relevant data that I can to be included. So if you or anyone you know is interested in the topic or has any resources that they think that would be helpful to the study, I'd love for them to reach out to me. So I've left my contact information on the slide here, but you can also reach out to my supervisor, Alan, at alan.bat1@monash.edu. Thanks.
Thanks, Jen. I knew you'd get in a thank you somewhere. I just,
yeah.
100%. Thanks for sharing your work. I know I'm involved in it, but I'm actually still shocked at the statistic that you provided at the start because I hadn't heard you share that before, of the burden of disease from opioid or from substance use overdoses in BC, and it's just shocking. So I think if anything, it provides even more support for the fact that this work needs to be done, and that this is a role that paramedics can play a big part in. And I was involved in the creation of the standard for the opioid response from the CSA group, and we had someone on that technical committee with living experience of substance use, and it was a totally different perspective that we've completely ignored up to this point in how we create education and how we create policy and things like that. So
yeah,
I thought
absolutely.
That was fascinating. Yeah.
No, absolutely. And you're so right. So we're also involved with some peer engagement groups. And one of the things that actually came up was actually from harm reduction outreach teams who were getting really frustrated when they would call 911 and the call taker would tell them to do CPR, even though the outreach workers knew that the patient was in respiratory arrest, knew how to check pulses, knew the patients had a pulse and didn't need to do CPR. And there would be a back and forth where the call takers were almost yelling at the outreach workers to do CPR. And so we took that feedback and we then implemented that back into our call taking system. So now when it is determined that the call taker is speaking with an outreach or harm reduction worker, and they tell the call taker that the patient has a pulse, that it's an opioid related or overdose arrest, that they stop asking them to do CPR. And in doing that, now we've fostered a much better relationship with our outreach workers. So
yeah, it just goes to show that perspective, that lived experience is super important from even their perspective as well, like from all or other caregivers that are involved in this process. You have a comment and a question on YouTube from Justin.
Oh, sure.
He said, it's tremendous amount of work. Congratulations and best of luck with finishing it.
He's
wondering if you can comment more on paramedic involvement in harm reduction, maybe like an existing program in BC as an example.
Sure. Yeah, absolutely. So I'm really excited to talk about this because it's really exciting work. So we are working on an initiative right now to allow paramedics to administer Suboxone. So for those who aren't familiar with Suboxone is buprenorphine and naloxone. So Suboxone cannot be abused. It is for withdrawal purposes only. If it is injected or it's crushed up and really broken down into any other form, it turns immediately into naloxone. So the purpose in trying to create an initiative that will allow paramedics to administer Suboxone is that we're just enhancing that step that is often missed when a patient suffers an overdose and then is just left to leave and then go and we really don't know what happens to them. So that's the initiative and it's a lot of work. So we've actually just had approved a Section 56 exemption from Health Canada that allows paramedics to administer Suboxone. And now we're currently working through a barrier in BC. And what that will require is a provincial health order from the Ministry of Health. And that's because currently in BC, PCPs cannot administer narcotics. And so because Suboxone is a narcotic, we need to get past that legislative barrier so that our PCPs can administer Suboxone, because if we're just able to allow our ACPs to administer Suboxone, we're missing, 90% of the population, because 90% of the time these patients are being tended to by primary care paramedics.
Thanks, Jen. That's yeah. I remember back when I was a paramedic student, I remember doing a case study on because we had a fairly large opioid issue in Ireland at the time when I was training, and actually the morbidity associated with opioid overdoses was something I hadn't really thought about, like just the mortality piece that we're often told about, but the falls, the burns, the trauma that they can sustain when overdosed, and the implications of that on their life when you combine it with things like uncertainty of housing and other social determinants and pieces of that. So I think to hear you bring up these other pieces that are lacking, for example, in the curriculum in BC, just because of the timeframes, that acknowledging those as a profession, and I feel like I'm beating the same drum here all day, but and as an educator, it's great to see the research coming forward, but it's also disheartening to realize that there's these huge portions of paramedic practice that we're not addressing properly, and I'm hoping to see that change in the next year or two in a major way in response to a better understanding with the NOSP. So I think just to acknowledge the fact that you're doing this work, but also the work that you're doing on the NOSP for the substance use portfolio piece within the working groups there, I think is really important to acknowledge. And I just want to wish you the best of luck with that too. So
no, for sure. Thanks, Alan. That's kind.
Thanks for sharing your work. And with that, I will bring things to a close. I know the YouTube stream is a couple of seconds behind, so I don't want to end it too quickly on people, but basically to thank all of you who have attended today for coming out and supporting the students here and our invited speakers, Rory Marshall from this morning and Jennifer Bolster this afternoon. I hope that you got some insight into where the current generation of paramedic students are focusing their energies, and then perhaps things that we need to do in response to that in order to make their workplaces safer, and in order to be able to help them to care for populations that we're probably not doing a good enough job for at the moment. So for those of you watching on YouTube, there will be an email come out to you in the next 2 to 3 weeks that will have an evaluation survey on it. Once you complete that survey, there will be access to a CME certificate. The link to the actual presentation on YouTube can be freely shared, and the video is open for people to look at. CME credits are only available for those who registered via Eventbrite prior to the day today. So other than that, again, thank you all for attending. Thanks to all the student groups. I have to say it again, I said it in writing in the Zoom, but I'll say it here. Extremely proud of all the work that you've done. I think you did a fantastic job today. It's not easy to present to people. It's probably harder in some ways to present online than it is to present to a room, because the room is finite and you can kind of see who's there. When you're presenting online, I said to you today, we had people tuning in today from Ireland, from Kenya, from the UK, from the US, and the video will no doubt be viewed by others from other countries after this when they wake up. For example, it's 3:30 a.m. in Melbourne. So our Australian colleagues are probably not watching it right now, but I know that the link will be looked at by a number of people there. And so you have had a reach much bigger than the room, and that can be a bit intimidating sometimes, but I think you did a great job. Very few technical issues, very good presentation by you. So I just want to say thank you for putting the effort in and putting together some great work to share. And then to thank Jen Doyle and Jennifer Boswell for supporting me as well in creating these projects and practicing the presentations and giving you feedback on them. So thanks to everyone, and enjoy the rest of your day. Sorry, just before I end, Jen, is there anything, I don't know if Jen is still here, anything you'd like to add at the end, Jen?
Thanks, Alan. No, I just wanted to express my congratulations to everybody for such excellent presentations. Alan, for your mentorship and support to the students, and yeah, overwhelming as an educator. Alan, I'll agree with you in terms of all the topics that we've got an identified gap, and we still have only a finite period of 2 years. So yeah, lots of work to be done, and very excited to see where things go.
Thanks, Jen. Okay, everyone. Thanks. Take care.